C6, C7, C8 and T1, the various spinal nerves which are taking part in the formation of the brachial plexus, right? And coming to the components of the brachial plexus, okay. So what are the various components of the brachial plexus? We have to remember in order, okay. Roots are nothing but the ventral rami of various spinal nerves, that is C5 to T1, okay. Those are called as roots of the brachial plexus, okay. And as you see in this diagram, roots will unite to form the trunks of brachial plexus, and you will be knowing the three trunks formed in the brachial plexus. What are they? Upper trunk, middle trunk and lower trunk. Upper, middle, lower trunks, okay. And the three trunks will be forming the divisions, anterior and posterior divisions, okay. Anterior and posterior divisions, and the divisions will give rise to formation of cords. Can you tell me the three cords which are formed in the brachial plexus? Yes, medial cord, lateral cord and posterior cord. These are the three cords of the brachial plexus, right? And the cords will give rise to the various branches. Okay. So these are the various components of the brachial plexus, okay. So the mnemonic for remembering the various components of brachial plexus in order: really tired, drink coffee now, okay. So definitely we have to remember the various components of brachial plexus in order, because even it may be asked in MCQ. What is the order of the various components of brachial plexus? Okay, roots, trunks, divisions, cords, and finally branches. N representing nerves, otherwise called as branches, okay. Nerves, otherwise we can say branches, okay. And so just now I have told you the formation and the various components of brachial plexus, right? So let me talk about the two parts of the brachial plexus, okay. So what are the two parts of the brachial plexus according to the location? See, out of the various components of the brachial plexus, the roots and the trunks, okay, roots and trunks, they are located just above the clavicle, okay. Do you see the location of the clavicle in this diagram? So just above the clavicle, that means within the neck, within the posterior triangle of the neck, we have the roots and the trunks, the first two components of the brachial plexus, okay. So the roots and the trunks will be called as supraclavicular part of brachial plexus, fine. And what about the infraclavicular part of brachial plexus? Below the clavicle, we have the cords and the branches of the cords, okay. Cords and the branches arising from the cords, they are located below the clavicle, so called as infraclavicular part of the brachial plexus, okay. So try to remember, the brachial plexus can be divided, components can be divided into two parts: supraclavicular part and infraclavicular part. Supraclavicular part contains roots and trunks, okay. And infraclavicular part contains cords and their branches, okay. So when I say infraclavicular part, that means it is present in the axilla. Below the clavicle we have the axilla, okay. This is the region called as axilla. So in the axilla we have the cords and the branches of the cords, okay, fine. Now let me talk about the branches arising from the various components of the brachial plexus, okay. So sometimes image based question may be asked, so you have to take care of this diagram also, okay. So what are the various branches arising from the various components of the brachial plexus? You will be knowing the various components of the brachial plexus, right? Roots, trunks, divisions, cords, and the cords will give rise to branches, okay. The branches of the cords, okay. So there are some branches which are directly arising from the roots and the trunks, okay. For example, you can see I have marked as number 1 and number 2 in this diagram, isn't it? These are the two branches arising directly from the roots of the brachial plexus, okay. Any idea about the nerves I am talking about? Yes, One is dorsal scapular nerve. Number 1 is representing the dorsal scapular nerve, which arises from C5 root. Okay. And another branch arising directly from the root is long thoracic nerve. Okay. Number 2 in this diagram is long thoracic nerve. What is the root value of the long thoracic nerve? It's a very commonly asked MCQ question. What is the root value of long thoracic nerve? The answer is, you can see it is arising from C5, C6 and C7. Okay. So the root value of long thoracic nerve is C5, C6 and C7. What about the root value of dorsal scapular nerve? C5. It is arising only from the C5 root. Okay. Then can you tell me the 2 branches arising from the trunks of the brachial plexus? What are the 2 nerves arising from the trunks of the brachial plexus? Actually, only the upper trunk, out of the 3 trunks, only the upper trunk gives rise to the branches, 2 branches. What are the 2 branches arising from the upper trunk of the brachial plexus? Yes, marked in the diagram as number 3 and number 4, which are arising from the upper trunk of brachial plexus. Yes, number 3 is suprascapular nerve and number 4 is nerve to subclavius. So suprascapular nerve and nerve to subclavius, these are the 2 branches arising from the upper trunk of the brachial plexus. Fine. Okay. So what will be the root value of these 2 nerves which are arising from the upper trunk of the brachial plexus? Yes, obviously C5 and C6, because you know, as you see in this diagram, the upper trunk is formed by the union of 2 roots, C5 and C6 roots. Okay. So I hope you are clear about the formation of the various components, right? As you see in this diagram, C5 and C6 roots both unite to form the upper trunk of brachial plexus, isn't it? And the C7 root simply continues as middle trunk of brachial plexus, middle trunk. Okay. And the C8 and the T1 roots both unite to form the lower trunk of the brachial plexus. Okay. So this is how the 3 trunks of the brachial plexus are formed: upper trunk, middle trunk, lower trunk. Okay. And we know trunks will be giving rise to the divisions, isn't it? All the 3 trunks, upper trunk, middle trunk, lower trunk, they will be dividing into 2 divisions each. What are they? Anterior and posterior divisions. Okay. A and P representing the anterior and posterior divisions of all the 3 trunks: upper trunk, middle trunk, lower trunk. Okay. And you will be knowing the trunks will be dividing into divisions, and all the divisions, they will unite to form the 3 cords. What are the 3 cords of the brachial plexus? Yes, lateral cord, medial cord, posterior cord. As you see here, the anterior divisions, okay, anterior divisions of the upper and middle trunks, both unite to form the lateral cord of brachial plexus. Fine. So lateral cord is formed by the union of anterior divisions of upper and middle trunks of the brachial plexus. Fine. What about the medial cord of the brachial plexus? As you see in this diagram, medial cord is the continuation of the anterior division of lower trunk of brachial plexus. Okay. Anterior division of lower trunk of brachial plexus simply continues as medial cord of the brachial plexus. Fine. And obviously the another cord, namely the posterior cord, will be formed by the union of posterior divisions of all the 3 trunks. Posterior divisions of all the 3 trunks: upper trunk, middle trunk, lower trunk. They will unite to form the posterior cord of the brachial plexus. So this is about the formation of the various components. You will be knowing, right? Roots will unite to form the 3 trunks. Trunks will be dividing into 2 divisions each, and the various divisions of the 3 trunks will be finally forming the 3 cords. Okay. and the cords will be giving rise to numerous branches. Fine. So as I told just now, when you talk about the branches of the brachial plexus, okay, branches of brachial plexus, what are the two branches arising directly from the roots of the brachial plexus? Yes, one is dorsal scapular nerve, which arises from the C5 root of brachial plexus. Another one is long thoracic nerve, okay. And here we have to remember some other important details about the dorsal scapular nerve and long thoracic nerve. Okay, so remember the dorsal scapular nerve is also called as nerve to rhomboids. Nerve to rhomboids because it supplies the muscles, namely rhomboid major and rhomboid minor, and also one more muscle, namely levator scapulae. So I want you to remember the three muscles which are supplied by the dorsal scapular nerve, also known as nerve to rhomboids. Okay, and this is a very simple question and very commonly asked question. Do you know the another name for the long thoracic nerve? Yes, long thoracic nerve is also called as nerve to serratus anterior because the long thoracic nerve supplies the muscle, namely serratus anterior, isn't it? So long thoracic nerve directly arises from the C5, C6 and C7 roots, and it supplies the serratus anterior muscle. So it is also called as nerve to serratus anterior. And what are the two branches arising from the upper trunk of the brachial plexus we have studied? Yes, one is suprascapular nerve. Another one is nerve to subclavius. Both will be having the same root value of C5 and C6 because they are arising from the upper trunk, which has the root value of C5 and C6. Okay, and remember the two muscles supplied by the suprascapular nerve. Okay, what are the two muscles supplied by suprascapular nerve? One is supraspinatus, another one is infraspinatus. Supraspinatus muscle and infraspinatus muscles both are supplied by suprascapular nerve. Fine. And another branch from the upper trunk, namely nerve to subclavius, supplies simply as the name indicates, it supplies the subclavius muscle. Fine. And now coming to the branches arising from the three cords. What are the various branches arising from the lateral cord, medial cord and the posterior cord of the brachial plexus? Okay, you will be knowing the mnemonic for remembering the branches arising from the three cords of the brachial plexus, isn't it? What is the mnemonic for remembering the three branches arising from the lateral cord of the brachial plexus? Yes, LML, isn't it? LML. Okay, lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. Okay, lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. These are the three branches arising from the lateral cord of the brachial plexus. Okay, so obviously all these three nerves will be having the root value of C5, C6 and C7, isn't it? They will be having the root value of C5, C6, C7 because you know the lateral cord is formed by the union of what? Anterior divisions of upper and middle trunks. That means C5, C6, C7. Okay. So usually the root value of musculocutaneous nerve will be asked in the MCQ. Okay, take care. Fine. And coming to the 5 branches arising from the medial cord, what is the mnemonic for remembering the 5 branches arising from the medial cord? Yes, M4U. Okay, 4 branches will start with M and 1 will start with U, M4U. So medial pectoral nerve, medial root of median nerve, then medial cutaneous nerve of arm and medial cutaneous nerve of forearm. And U is representing ulnar nerve. So these are the 5 branches arising from the medial cord of the brachial plexus. Okay, so you know medial cord is the continuation of the anterior division of the lower trunk. Anterior division of the lower trunk continues as medial cord. You know the lower trunk is formed by C8 and T1 nerves. So that's why all the branches of the medial cord, they have the root value of C8 and T1. C8 and T1. Okay. With the exception of ulnar nerve. Okay. Ulnar nerve not only has the C8T1 contribution, also it receives contribution from C7. This is a very common MCQ again. Okay. What is the root value of ulnar nerve? The ulnar nerve root value is C7, C8 and T1. Not only C8, T1, C7 also. C7, C8 and T1. Fine. Then coming to the 5 branches arising from the posterior cord of the brachial plexus, the mnemonic is ulnar, U-L-N-A-R, ulnar. These are the 5 branches arising from the posterior cord. Okay. U and L representing the upper and lower subscapular nerves. Subscapular nerves. Fine. Then N is nerve to subclavius. Nerve to latissimus dorsi. Nerve to latissimus dorsi. Okay. Nerve to latissimus dorsi. Okay. And the 2 main branches arising from the posterior cord are represented by A and R, namely axillary nerve and radial nerve. Axillary nerve and radial nerve. Okay. So these are the 5 branches arising from the posterior cord. Fine. Upper and lower subscapular nerves, nerve to latissimus dorsi, axillary nerve and radial nerve. Here they will be mainly focusing on what is the root value of axillary nerve, what is the root value of radial nerve. Okay. Remember, the root value of axillary nerve is C5, C6 and the root value of radial nerve is C5, C6, C7, C8 and T1, starting from C5 to T1. Fine. Okay. So this is about the branches arising from the 2 branches from the roots, 2 branches from the upper trunk and the various branches arising from the 3 cords. Okay. So can you tell me now which component of the brachial plexus does not give rise to any branches? Which component of the brachial plexus does not give origin to any branches? You know the various components, right? Roots, trunks, divisions, cords. Okay. So which component of brachial plexus does not give rise to any of the branches? Exactly, divisions. Okay. The divisions of the brachial plexus, divisions do not give rise to any branches. You are able to see the branches arising from the roots, branches arising from the trunks, and branches arising from the various cords. Fine. But the divisions of the brachial plexus, they do not give rise to any branches. Okay. So divisions do not give rise to any branches. This question has been asked. Okay. Yes. Now, and some more important MCQ questions here. Out of the various branches of the brachial plexus, can you tell me which is the largest branch of the brachial plexus? Anybody? Exactly. Radial nerve. Okay. Radial nerve is the largest branch of the brachial plexus. And you know, radial nerve is a branch arising from which cord of the brachial plexus? Posterior cord, isn't it? So it is the main continuation of the posterior cord of the brachial plexus. Fine. And you know the root value C5, C6, C7, C8 and T1. Fine. So it is the largest branch of brachial plexus and it is the main continuation of posterior cord of brachial plexus. Fine. And one more important thing, the median nerve also has the same root value of C5 to T1, C5 to T1. Okay. Because not only radial nerve, median nerve also has the same root value of starting from C5 to T1. Because as you see here, the median nerve is formed by 2 roots. One is lateral root of median nerve. Another one is medial root of median nerve. Okay. Both roots unite to form the median nerve. And you know the root value of lateral root C5, C6, C7. And you know the root value of medial root of median nerve C8, T1. So obviously the root value of the median nerve as a whole will be C5, C6, C7, C8, T1, isn't it? Fine. And you know the root value of axillary nerve, right? C5, C6. Can you tell me the 2 muscles supplied by axillary nerve? What are the 2 muscles supplied by axillary nerve? Yes, one is deltoid muscle, another one is teres minor muscle. deltoid and teres minor. These are the two muscles supplied by the axillary nerve. Root value is C5 and C6. Fine. Fine. Now, coming to the final topic, applied aspect of the brachial plexus. That means what are the common injuries occurring at the level of brachial plexus? Okay. So there are two brachial plexus injuries we are going to discuss. One is called as Erb's palsy or Erb's paralysis. Okay. Another one is called as Klumpke's palsy or paralysis. Okay. So the applied aspect of the brachial plexus, one is Erb's palsy, another one is Klumpke's palsy. So let's discuss the important things regarding the two brachial plexus injuries. Okay. So let's talk about the Erb's palsy first. Okay. So Erb's palsy is due to injury to the upper trunk of the brachial plexus. Okay. Erb's palsy is due to injury to the upper trunk of the brachial plexus. That means, can you tell me what are the nerve roots involved in Erb's palsy? I told it is due to injury to the upper trunk. So obviously, what are the two nerve roots involved in the Erb's palsy? Yes, C5 and C6 roots. Because upper trunk is formed by the C5 and C6 roots, isn't it? And this Erb's palsy is due to injury to the particular point called as Erb's point. Erb's palsy is due to injury to the Erb's point. Okay. Okay. Now the question arises, what do you mean by Erb's point? Isn't it? So Erb's point is the meeting point of 6 nerves. Erb's point is the meeting point of 6 nerves, which is located at the upper trunk of brachial plexus. Upper trunk of the brachial plexus. Okay. And obviously, injury to the Erb's point results in Erb's palsy. Fine. See this diagram to understand the meaning of location of Erb's point. Just now I told Erb's point is the meeting point of 6 nerves. Okay. So what are the 6 nerves meeting at the Erb's point? C5 and C6 roots. C5 and C6 roots. Then you know C5 and C6 roots unite to form the upper trunk of brachial plexus, isn't it? This is the upper trunk. You know the two branches arising from the upper trunk of brachial plexus, isn't it? One is suprascapular nerve, another one is nerve to subclavius. Suprascapular nerve and nerve to subclavius, isn't it? And you know, upper trunk will be dividing into 2 divisions. What are they? Anterior division and posterior divisions of the upper trunk, isn't it? So these are the 6 nerves meeting at the so-called Erb's point. Fine. So if there is injury to the Erb's point, it will result in one clinical condition known as Erb's palsy. Fine. So now coming to the deformity, that means what is the position of the hand in case of Erb's palsy called as? Anybody? So what will be the position of the hand in case of Erb's palsy? Yes, it is called as policeman's tip deformity. Okay, policeman's tip deformity. Please take care. This is again a commonly asked image based question. Okay, so they will be giving this image and they will be asking what is the clinical deformity in this image, like that the question will be. So this image is showing the Erb's palsy and the clinical deformity, okay, is called as the position of the upper limb in Erb's palsy is called as policeman's tip deformity. Okay. Okay, fine. So what is the policeman's tip deformity? What is the condition? As you see here, the arm is adducted and medially rotated. Arm is adducted and medially rotated. Then what about the forearm? Forearm is extended and pronated. Okay. And hand or you can say wrist. Hand or wrist is flexed. Okay. So this is the position of the upper limb in the so-called Erb's palsy or policeman's tip deformity. Arm is adducted. You can remember as arm is adducted. Okay, adducted and medially rotated. Okay. Forearm is extended and pronated. Hand is flexed. That means you can understand the opposite movements are lost. There is loss of opposite movements in Erb's palsy. That means arm cannot be abducted. Loss of abduction and lateral rotation, loss of flexion and supination, and the loss of extension of hand. Okay, so please take care. This is a very important image based question, and you have to know what is the position of the arm, forearm, and hand in the so-called policeman's tip deformity, and the opposite movements the patient cannot perform. There is loss of opposite movements, whatever we have discussed here. Right? And finally, coming to the okay, so what are the possible causes for Erb's palsy? Okay, so the two main causes of Erb's palsy is one is birth injury. Okay, birth injury. When the forceps is used for delivering the baby, there may be injury to the upper trunk of the brachial plexus. Okay, so birth injury, that is forceps delivery. And another one is fall on the shoulder. Okay, fall on the shoulder. So in this condition also, upper trunk of brachial plexus may get injured, leading to the so-called policeman's tip deformity in Erb's palsy. Fine. Now, let's talk about the Klumpke's palsy. Okay, I told you Erb's palsy is due to injury to the upper trunk of the brachial plexus, that is C5 and C6 roots. What about the Klumpke's palsy? Klumpke's palsy is due to injury to the lower trunk of brachial plexus. Lower trunk of brachial plexus. Can you tell me the two nerve roots involved in Klumpke's palsy? Yes. Lower trunk is formed by the C8 and T1 roots, isn't it? So in Klumpke's palsy, C8 and T1 roots are involved, mainly T1 root. Mainly T1 root. Okay. This is again asked. This question has been asked again. Okay. And the two clinical features of the Klumpke's palsy will be, one is claw hand deformity, another one is called as Horner syndrome. Horner syndrome. Okay, so claw hand deformity we have already discussed. Okay, in the yesterday's session. So please go through that video. Okay, so in order to understand the claw hand deformity, and one more clinical feature of the Klumpke's palsy other than claw hand deformity is called as Horner syndrome. Horner syndrome, which is due to involvement of T1 spinal nerve, mainly to be specific, ventral ramus of T1 spinal nerve. Okay, injury to the ventral ramus of T1 spinal nerve. Otherwise, you can say white ramus communicans of T1 spinal nerve. The clinical condition is called as Horner syndrome. Okay. Fine. So these are the possible causes for what? Klumpke's palsy. Okay. Klumpke's palsy, the possible causes are, again, one is birth injury, another one is undue abduction of the arm. Okay. Undue abduction of the shoulder joint. Okay. So the clinical feature is claw hand, in which there will be hyperextension of the metacarpophalangeal joint and hyperflexion of the interphalangeal joints. Okay, this is the position of the hand in the so-called claw hand deformity. Okay, which occurs in the Klumpke's palsy. Okay, fine. And finally, remember, this Klumpke's palsy is due to paralysis of intrinsic muscles of the hand. Klumpke's palsy is due to paralysis of intrinsic muscles of the hand, which we have discussed in yesterday's session. Okay. So it is due to paralysis of intrinsic muscles of the hand, which are supplied by C8 and T1 spinal nerves. Supplied by C8 and T1 spinal nerves. This question also has been asked. Okay. Okay. So that's the end of the today's session regarding the brachial plexus and its injuries. Okay. Thank you all. Thank you all.
You see the medial lemniscus. Fibers, as you know, these are the dorsal column fibers which have decussed in the lower medulla. They are crossed and they are ascending up in the upper part of the medulla. So all the crossed fibers of the medial lemniscus are ascending. Okay, in this part of the medulla. Okay, medial lemniscus. Next, if you see sites which communicate with the cerebellum, cerebellar peduncle.
Good evening, friends. So today, for medicine point of view, we'll see one high important MCQ, which is most commonly asked with respect to CNS, case of medicine. Okay. First question. Yeah. A 45-year-old patient came with sudden onset weakness of the limbs, and since 2 hours, a NCCT head was done, which is given below. His BP is 200/100 mm mercury. What to do next? And they have given you one CT finding of that patient. Options are A, go for thrombolysis with IV alteplase as it is within window period. Option B, control BP first by giving labetalol and then go for thrombolysis. Option C, don't thrombolyze the patient as the CT scan shows bleed. Option D, try for mechanical thrombectomy in this patient. So basically, if you see this question, what all they are trying to ask? They have given you one clear-cut history of a patient with stroke. How are you going to manage stroke? Very important thing, both practical as well as INI-CET point of view. So if you see here, first you should know what is the window period for stroke. Next, what you should know is BP is 200/100. So you should know the BP control in case of stroke. And next, if you see the options, thrombolysis, when you should go for thrombolysis. Indications of thrombolysis you should know. And within what window period you can go for thrombolysis, and what are all the other options available other than thrombolysis. If the window period is excess, what more options are also available? That point also you should know. Next, they are telling if the CT scan is showing bleed. So that means interpretation of CT scan in case of stroke patient. So that also you should be knowing. And the last option is telling mechanical thrombectomy in this patient. So what are the indications for mechanical thrombectomy in this patient? All these, if you know as a whole, you will be able to answer this clinically high oriented question. Okay, let's see. First, let's see how to interpret a CT scan in case of stroke. Basics, what basic you should know to interpret a CT scan in case of stroke. Yeah. So, first question, a patient coming with stroke features, NCCT head should be done immediately. That everyone knows. But what is the time cutoff within which you should get an NCCT done at any cost for any patient with stroke? It is, can anyone guess? It's nothing but 20 minutes of arrival. Within 20 minutes of arrival, you should get NCCT head of the patient in case of a stroke. Okay. Why are we getting NCCT head of in a case in a patient with stroke? It is not that we are going to diagnose what is the ischemic stroke, what level of ischemia is going on, what artery is blocked. No. This NCCT head is done only to rule out hemorrhage. Okay. If the patient has any signs of bleed, like intracerebral hemorrhage, then we can see easily NCCT head as a hyperdense lesion. Whitish areas will be seen in CT, which suggestive of bleed. So if you say in this picture, right side, if you see, it consists of a whitish area surrounded by a grayish zone. Can you see that? So this whitish areas represents bleed. And the surrounding, if you see, there is a grayish zone around it, which means some fluid. Gray zone means fluid. So some edema is surrounding the bleed. This is a characteristic picture you never forget in case of a intracerebral hemorrhage CT scan. Okay. Yeah, see this. Whitish areas representing hemorrhage and edema. Okay. Next, same, see the CT scan in the left part. Here, if you see, it's dark gray, meaning if some tissue is getting infarcted, necrosed, it will appear less hypointense in CT scan. So those hypodense areas in CT scan, we call them as infarct. Okay. So mostly you can never see infarct within 20 minutes of arrival in case of a stroke patient. Okay. They're just doing the CT scan only to rule out hemorrhage. Okay. Next, if you see, infarct might not be visible always. Okay. This also you should know. So when you compare to the question given in the CT scan given in the question, what is happening in the CT scan given in the question? There is no signs of any bleed. So the CT scan given in the question is that of a ischemic. Okay. Yes. Now, ischemic stroke management, how are you going to do? If it is a hemorrhagic stroke management, it is entirely different. Okay. That you should be knowing. So next is, yeah. So next is, if you see, so ischemic stroke we have diagnosed with this. Now, how are you going to manage this ischemic stroke? Okay. Next, that is the point. Yeah. Management of ischemic. First, if you see, the most important management in emergency in case of a stroke patient is airway, breathing, circulation. Okay. Airway. Why do you want to secure the airway? In stroke, mostly the patient's sensorium will be altered. If it's a cortical stroke, okay, the patient might get seizures at any time. So it's very important to secure the airway in case of a stroke. Next, breathing. Breathing, when breathing comes major importance in case of stroke. In case of, like in stroke, when the patient becomes altered, if the patient vomits or something, that will get aspirated easily. Okay, so the patient might have a component of aspiration pneumonitis also. If the patient has aspirated enough to cause severe type 1 respiratory failure, hypoxia, in such cases, you should be giving oxygen for the patient first by face mask, non-rebreathable mask, NRBM. If that is not also possible, the patient is gasping, then you should be going for intubation. Breathing becomes an integral component of your management. Next, if you see circulation. Circulation is also important in case of stroke. That's what we are going to see now. So the BP control in case of ischemic stroke. What is the cutoff? And also, what are you going to see in emergency? BP as well as random blood glucose, sugar. All these things you should be checking within 10-15 minutes, and you should send the patient to CT scan. Okay, within 20 minutes of arrival, all these should be done and CT scan should be performed, and you should have ruled out intracerebral hemorrhage by the 20th minute. Okay. Yeah. Next, if you see, next let's see the management, ischemic stroke management as well as hemorrhagic stroke. So if it is ischemic stroke, you should have an idea of time since symptom onset. Okay, that will guide your management in ischemic stroke. If it is hemorrhagic stroke, whatever may be the time since onset, your management remains the same. Okay, yeah. Next, let's see how to manage the BP in case of ischemic stroke. Okay, why it is that much important to maintain your blood glucose? Okay, why it is that much important to maintain the blood? Yeah. So now we will see the dextrose control in case of a patient with ischemic stroke. Why is the dextrose control that important in case of ischemic stroke? First is hypoglycemia as well as hyperglycemia can aggravate this infarct extension. How? See, if glucose supply is getting less to the tissues, then automatically that infarct region will get enlarging. More tissues at the region of infarct, which we call as penumbra, which are salvageable tissues. If they get low glucose, their metabolism is already low because of the low blood supply. And combined with low glucose will make them more prone for more injury, more infarct, and infarct expansion. So, hypoglycemia should be taken as an emergency in these patients and should be treated. Next, hyperglycemia. 140 to 180 should be your target blood glucose. If it is more than 180, then that means that even hyperglycemia can cause dysglycation in products, free radical production. All these things can also aggravate the infarct expansion. So only we treat hypo as well as hyperglycemia as an emergency in case of an ischemic stroke patient. Okay, so this is the need for you to know the cutoffs of hypo as well as hyperglycemia and how are you going to treat. Okay, yeah. Next, Next, let's see the BP control. So BP control, if you see, first, in case of stroke, you should be planning whether the patient is eligible for thrombolysis or not. If the patient has come to you within 4.5 hours, then that means he is eligible for thrombolysis. If he is eligible for thrombolysis, your BP control should be aggressive, meaning BP should be less than 185/110. It's very important. This cutoff is okay. Your BP control should be there if the BP goes above 180/110. You can give labetalol, which is an alpha plus beta blocker, which is used in hypertensive emergencies as well as urgencies. So labetalol becomes your drug of choice. Treat the hypertension there. Bring the BP below 185/110 if the patient is thrombolysis eligible. Okay. Or you can give other drugs like calcium channel blockers, which are known as nicardipine, hypertensive emergency drugs. Yeah. So goal should be BP less than 180/110. Next, if the patient is thrombolysis not eligible, most of the cases will get like this only. They will come above, out of side the window period. So there, your BP control can be liberal. Like your BP control can be kept less than 220/120. Because see, some major vessel in the supplying the cerebral cortex or subcortex is blocked. So only if the BP compensates and increase to some extent, it can pass above the clot and it can perfuse the tissues. So hypertension is actually manifested even in normal individuals in case of stroke patients. To maintain the cerebral perfusion, your BP must increase. So only, but it shouldn't increase more than 180/110 if you are thrombolysing a patient. Because if you are thrombolysing a patient and if the BP is increased, means that can lead to your alteplase or etelplase, your thrombolysis drugs plus hypertension can cause bleed in the patient. So only we are giving aggressive BP control in case of those patients who are eligible for thrombolysis, and the cutoff is 183/110. Next, thrombolysis not eligible, we are liberally treating less than 220/120. This is your BP in case of stroke. Next, so in our patient, let's see what has happened. So first, a patient has come to you with ischemic stroke. Now, how are you going to manage it? First, time since stroke onset you are going to see. If the time is less than 4.5 hours, then he is within the window period. If he is more than 4.5 to 24 hours, or if he is more than 24 hours, 3 chances are possible. If he is less than 4.5 hours, then he is within window period. Thrombolysis is indicated in these patients. Okay, so whether indicated or not, you should have those set of indications as well as contraindications. You should go and see whether they are indicated or not. Okay, so you should know the indications as well as contraindications for this. So if it's indicated, you can go for IV alteplase. This is the drug of choice for thrombolysis in case of ischemic stroke, which is a recombinant tissue plasminogen activator. Okay, yes. What if the patient is within the window period, but he is not eligible for thrombolysis? So what you can do? That becomes your next question. So, if he has any contraindications for thrombolysis, then you can go for CT angiography. Okay, CT contrast given angiography you should see, and if possible, you can do mechanical thrombectomy in these patients. In CT angiography, you are going to localize where is the clot, and through guide wire and interventional procedures, you can suck out the clot. Okay, this is mechanical thrombectomy. Okay, only in those patients who are not eligible for thrombolysis within the window period, you can go for mechanical thrombectomy. Okay, so this is for the patients who come within window period. What if the patient is between 4.5 to 24 hours? There, you can go for mechanical thrombectomy directly. Only option possible in this stage is mechanical thrombectomy. If he is eligible for it, then you can go do mechanical thrombectomy. Or if he is not eligible for it, then only option is your antithrombotics like ecosprin or clopidogrel, atorvastatin. All these you can give. If the patient is more than 24 hours time since onset, then only option left with you is antithrombotic agents. This is a complicated protocol. I made it simplified for you. This is how you should approach a patient with mixed stroke. Okay, so you should approach the patient with ischemic stroke. Okay, so next, but you might be confused that what may be the indications and contraindications and how to give this thrombolysis agents. Next, we will learn how to give these things. I told IV alteplase, which is a recombinant tissue plasminogen activator, the drug of choice. Activates plasmin. So plasmin will cut off all the fibrin threads, thus it will lyse the clot. Okay? Yeah. So how to give this alteplase? First, you should give 10% as an IV bolus. Okay. And remaining 90%, you should be giving it as an infusion, which will be going for 1 hour. It should be done in a center where neuro ICU is available. Okay. Next, what are the indications of thrombolysis? The interesting indication is age should be more than 18 years. You can't risk to thrombolyze any child less than 18 years. Young onset stroke is also common. So many causes are there, but still you should not go for thrombolysis in young onset stroke. Okay, only age more than 18 years. First indication. Next, time since onset, as we have discussed, if it should be less than 4.5 hours, the window period for stroke. And BP should be less than 180/100, as we have discussed. Okay, by giving labetalol, we can control it. Less than 180/100 is eligible for thrombolysis. Then, clinical diagnosis of ischemic stroke. Ischemic stroke is there, or CT guided diagnosis also you can do, ruling out hemorrhage. These are the easy indications which we have learned from these approaches. Okay, what are the contraindications? How to remember it easily? Let's take some cartoons for it. First, see, in brain. Okay, in brain, if you see prior history of any hemorrhagic stroke, okay, or subarachnoid hemorrhage. Okay, if the patient has had hemorrhage, the two within the brain, subarachnoid hemorrhage, extradural hemorrhage, intracerebral hemorrhage, in his life, okay, whenever it is, then he becomes an absolute contraindication for thrombolysis. You should never thrombolyze the patient. Okay, that becomes your first contraindication. Or any head injury. Okay, any head injury in the last 3 months, that also becomes a contraindication. Next, ischemic stroke. Oh, it should be in the last 3 months. If there is any ischemic stroke, then it becomes a contraindication. Okay. Next, any active abdominal bleeding, GI bleeding, like bleeding peptic ulcer, Nelina-Key history, all these becomes a contraindication for thrombolysis, and this active peptic ulcer bleeding should be less than 21 days. And also, any patient who have undergone a surgery in the last 21 days, that also becomes a contraindication. Then, any person who had any active malignancies of GI tract active malignancies are there. Then if you give thrombolytic agents, that will continue to bleed like anything. GI bleeding will start. So you should never give in such patients. Then active infective endocarditis. This many of them don't know. It's a high yield point also, because in active infective endocarditis, why you should not give thrombolysis? Just think, in infective endocarditis, what is happening is there is infection in the endocardium of the heart valves. So there are vegetation starts to form on the valves as well as the endocardium of the heart. These vegetations can get detached. Okay, these vegetations can get detached, and these vegetations can also embolize the brain, resulting in embolic strokes. So, in such patients, if you give thrombolytic agents, infection combined with the bleeding agent will drastically bleed. Okay, so it becomes an absolute contraindication. Next, so all these are contraindications for thrombolysis. Indications, we saw 4 small and easy indications to learn, and contraindications are very important in respect to health effects. Okay, yeah. Next, if you see, any aortic dissection becomes also the contraindication. Okay, so thus we learned the indications and contraindications of thrombolysis, approach to a patient with stroke, how to approach the patient with stroke. Next, BP control in case of ischemic stroke, and how to see a CT in case of a stroke, and how to handle ABC, airway breathing circulation, BP as well as stretch dose control. Okay, yeah. So the answer will be, for this patient, he has come within the window period, so he is eligible for thrombolysis. He is an ischemic stroke patient. Yes. He has come within window period. Yes. So he is eligible for thrombolysis. Yes. But still, BP is more than 180 by 110. So first, you should go for control of BP in this patient. Okay. Then you should start giving thrombolysis. So option will be B. Control BP first by giving labetalol, then go for thrombolysis. That's it for the day. Okay. We'll see tomorrow with another interesting question and another interesting approach. Mostly the management aspects are very important in case of INICET. Okay. We will learn one more management aspect tomorrow. Till then, thank you.
Good evening, everyone. We'll quickly start off. Okay. So yesterday we saw about hypochromic anemias. The last NEET PG and 2 years before, there was a question regarding macrocytic anemias. Okay, so this NEET PG macrocytic anemia, they had given a history of around a techie who was especially on food. He had poor diet food and he had anemia symptoms and signs. So what is the most probable cause? Okay, so it was either folate or B12. That was the question. We'll see how to tackle it. So before getting into the thing proper, let me tell you. One thing, what are macrocytes? Macrocytes are nothing but RBCs whose size, according to standard books, more than 98 femtoliters. Few books give it as more than 100 femtoliters. Okay, so anything is okay. So macrocytes are RBCs with this size. Okay, in general, when you see a peripheral smear, how do you say they are macrocytes? You will compare with the size of a nucleus of the lymphocyte, small lymphocyte. They will appear bigger. One more characteristic feature of this macrocyte is they usually don't have central pallor. They usually don't have central pallor. Okay, and they can be oval or round. They can be oval or round. Fine. Now, when it comes to macrocytic anemias, now you already know the DDs for hypochromic anemias. Okay, so when it comes to macrocytic anemias, I'll just tell you a mnemonic. Remember it like this: A, B, C, D, and E and F. Okay. So A is for alcoholism. So in alcoholism, you see, we all know macrocytic anemias, vitamin B12 and folate, you all will answer. But you have to know the other causes of macrocytic anemias also. So A is alcoholism. Okay. For B, we have B12 and folate deficiency. Okay. And then C, it is compensatory reticulocytosis, which is seen in any hemolytic anemia. Why in reticulocytosis the MCV is high? Because reticulocytes are larger than the RBCs, isn't it? So whenever there is hemolytic anemia, there is increased number of reticulocytes. So in general, the Coulter will give you a raised MCV value. Okay. Then what is D? For D, you can remember it as drugs. Okay, D, you can remember it as drugs. When it comes to drugs, you can have drugs whose mechanism of action is antifolate, including methotrexate, pyrimethamine, okay, trimethoprim. Fine. Along with this, you have drugs which inhibit DNA synthesis, which includes hydroxyurea. Most important I'm mentioning, most of the anti-cancer drugs will cause, but most important I'm mentioning, purine antagonist, 6-mercaptopurine, and pyrimidine antagonist are, okay, cytosine, arabinocyte. Fine. So these are the drugs which commonly causes macrocytic anemia. Along with this drug, you have to remember nitrous oxide during anesthesia. Okay, fine. After that, E, endocrine cause, hypothyroidism. Fine. Then F is in fetus, we have macrocytes. It is normal for a fetus to have macrocytes. Fine. Okay, so in this, first we will initially get into vitamin B12 deficiency. What are the causes? Okay, so before that, before getting into that, see, macrocytic anemias, I told you the list, isn't it? So this macrocytic anemias can be megaloblastic or normoblastic. This normoblastic and megaloblastic is based on the presence of megaloblasts or normoblasts. These are erythrocyte precursors. If the erythrocyte precursors are also larger than megaloblastic, then they are called megaloblastic macrocytic anemias. If they are normocytic and only we are seeing macrocytes on the peripheral smear, it is normoblastic macrocytic anemias. What are these megaloblasts? Megaloblasts are nothing but, see, usually macrocytic anemias, we are here, megaloblastic anemias, we are speaking about vitamin B12 and folate. Okay, in this vitamin B12 and folate deficiency, there is an asynchrony between the nuclear and the cytoplasmic maturation. That means there is a lag in nuclear maturation. They should have gone hand in hand, but there is a lag in nuclear maturation. So what will happen to the nucleus? The nucleus will still be larger with open chromatin. The nucleus will be still larger with open chromatin, but hemoglobinization would have already occurred in the cytoplasm. Okay, and these cells still remain large with open chromatin nucleus, and hemoglobinization would have occurred. This is megaloblast. So if these are found in the bone marrow, they are called megaloblastic anemias. Usually when these megaloblasts are found in the myeloid series, we see giant band forms. Okay, band forms which are larger than the regular band forms. Band forms are nothing but neutrophil precursors, isn't it? So those cells are also giant. Okay, so these 2 points you have to remember. Okay, so in general, macrocytic can be classified into megaloblastic and normoblastic. The megaloblastic causes are chiefly vitamin B12 and folate deficiency, and drugs which affect the vitamin B12 and folate deficiency. So coming to the causes of vitamin B12 deficiency, nutritional. Nutritional, see, basic source of vitamin B12 is animal source of food. Okay, animal food. So especially this is seen in strict vegans. This is seen in strict vegans. Okay. Then one more thing you have to know, how much of a food you take or how much of a supplement you give only 1 to 2 microgram of vitamin B12 is absorbed from the body. How much ever you supplement, only this amount can be absorbed orally. I'm speaking about oral, okay? So how much ever you supplement or how much ever food you take, however rich it is, this is the amount which is going to get absorbed. So we'll see vitamin B12 deficiency in strict vegetarians. Then when it comes to gastric causes, we have to rule out atrophic gastritis and pernicious anemia. Fine. Then next, coming down, we have to see congenital lack of abnormality in intrinsic factor. This is a congenital defect. Okay, so this I will tell you in detail because it's a very potential question. I'll tell you in the next slide. Okay, and then when the patient is having total or partial gastrectomy. Fine. What are the intestinal causes? Intestinal causes, nothing much you have to remember. I want you to remember chronic tropical sprue, and I want you to remember ileal resection. Okay, the rest is okay. You can just leave the rest. I want you to remember strict vagins and then gastric causes. Then you have to remember tropical sprue and ileal resection. Okay, because vitamin B12 is basically absorbed in the ileum. Fine. So folate deficiency, when it comes to causes of folate deficiency, okay, see this one, first and most important cause is pregnancy. You have to think of pregnancy. Okay, pregnancy is the most common cause because there the folate requirement is very high. The next point I want you to remember is gluten-induced enteropathy. See, in gluten-induced enteropathy, what you can either get folate deficiency or iron deficiency anemia. B12 is not, I mean, you don't get B12 deficiency in gluten-induced enteropathy. So if it is a macrocytic anemia and they give history of gluten-induced enteropathy, then you have to think of folate deficiency. Okay. Apart from this, I want you to remember pregnancy. Yes, that you know. Hemolytic anemias. This is a potential question. In hemolytic anemias, folate deficiency will predominate. Okay. Fine. And next, of course, anticonvulsants and barbiturates. The cause is not known. How the mechanism what is the mechanism it causes folate deficiency? We don't know, but they again cause folate deficiency. What you have to remember here: pregnancy, hemolytic anemias, gluten-induced enteropathy. Okay. So, what are the functions before that? Before that. Okay, see, B12, what are the forms of B12 which we can get? We can get methylcobalamin, okay, we can get adenosylcobalamin, okay, hydroxycobalamin and cyanocobalamin. Methyl and adenosyl are regularly found, okay, naturally found. Hydroxycobalamin and cyanocobalamin are we give commercially produced and we use it for treatment. Especially we use hydroxycobalamin. Fine. And apart from this, see, vitamin B12 is absorbed once it is taken in the food. It is broken down from its protein complexes. And then what happens to this vitamin? What happens to this vitamin B12 is it has to be carried in the saliva. It will get attached to transcobalamin. Okay, transcobalamin. Then later, it enters transcobalamin 1. It enters the stomach, and then in the stomach, what happens? In the presence of stomach and the duodenum, in the first part of duodenum, pancreatic proteinase, it is split, okay? And then it combines in the stomach, the free vitamin B12 also combines with intrinsic factor, which is produced by the parietal cells. That is why intrinsic factor plays an important role in pernicious anemia. What is pernicious anemia? It is an autoimmune disorder where antibodies are found against components, two components, potassium, hydrogen, ATPase pump, okay, and intrinsic factor. The antibodies against intrinsic factor are very specific for pernicious anemia, but they're usually found only in 50% of the patients. But 70% of the patients show antibodies against potassium hydrogen pump, but they are less specific. Okay, they are less specific. So if we see antibodies against intrinsic factor, it is very specific for pernicious anemia. So vitamin B12 will combine with intrinsic factor, then it moves down. Okay, it moves down, it is absorbed in the proximal duodenum. Okay, and then inside the cell it is transferred into the portal circulation. In the circulation, it is bound to transcobalamin 2. Transcobalamin 2. Okay, see that I told you one congenital defect, isn't it? That congenital defect, whatever I was speaking about, is a defect in the receptors for vitamin B12 intrinsic factor complex, which is called cubum. Cubum. Okay, when there is a defect, though there is vitamin B12 which is bound to intrinsic factor, the body will not be able to absorb. This is seen in infants. So they will have congenital megaloblastic anemia along with that proteinuria. Along with that, they will have proteinuria. Fine, that is one cause of congenital vitamin B12 deficiency. I'm just mentioning the questions which are asked, okay, because this is a wide topic. And this, of course, you all know in your biochemistry. Why I have put up this here especially is, see, adenosyl B12 is an important coenzyme for conversion of methylmalonyl CoA to succinyl-CoA. Fine, and this, when in this presence, methyl tetrahydrofolate acts as a methyl donor to homocysteine. Okay, acts as a methyl donor to homocysteine in the presence of methylcobalamin to form methionine. So whenever there is deficient methylcobalamin, what will happen to the homocysteine levels? It will raise. Okay, whenever there is deficient tetrahydrofolate, also homocysteine level raise. That much you have to know. So increased homocysteine levels are seen in deficient B12 and folic acid. Okay, but increased methylmalonyl CoA is seen only in deficient B12. Fine. Though these tests are not usually performed, this is a potential question, so you have to know this point here. And then apart from this, 1 minute. So coming to symptoms, clinical features. Coming to clinical features of folate and vitamin B12 deficiency, what all the patient can have, you all know macrocytic anemias will be there. All that is okay. Anemia means glossitis, beefy tongue will be there, cheilitis will be there. All that is okay. What is special for vitamin B12 deficiency? For vitamin B12 deficiency, the patient, each sentence is a question. They will have progressive neuropathy. They will have progressive neuropathy. Fine, first thing. They will have peripheral neuropathy. This, it's a progressive type. They will have peripheral neuropathy. Okay, this will be symmetrical, more common in the lower limbs than the upper limbs. Okay, first, initially it will start with the lower limbs, especially the sensory loss of the second toe. Okay, so it will be symmetrical, peripheral neuropathy, lower limbs more common than upper limbs. All these are questions. Okay, and in the sensory pathway, which pathways are affected? Dorsal and lateral. So dorsolateral pathways are affected. Why these pathways are affected? Because I told you in vitamin B12 deficiency, what happens is this methylcobalamin is not there, isn't it? So homocysteine levels are increased. This homocysteine, increased homocysteine will interfere, okay, will interfere with myelin formation. Okay, sorry. Methylmalonyl CoA also will interfere with myelin formation. Fine. Apart from this, one more point you have to remember is, apart from that neurological symptoms, the patient can show psychiatric symptoms, delirium. In case of children, motor milestones can be delayed. Okay, in case of children, impaired motor functions, milestones can be delayed. Okay, so all these neurological symptoms, when we give treatment with vitamin B12, the peripheral neuropathy is treatable. The peripheral neuropathy is treatable. Okay, but the spinal cord defects, especially the dorsal and the lateral columns, when they're affected, that is not treatable. Okay, that is not treatable. But in case of folate deficiency, you will see neural tube defects. You will see neural tube defects. Okay, that is why empirically we give 5 milligram of folate tablets to all the pregnant ladies. Okay, we give 5 milligram folate tablet to all the pregnant ladies. Fine. So this much for today. I will tell you the details about treatment of vitamin B12 deficiency and folate deficiency in the next class. Thank you.
So we'll start with microbiology discussion on morphology and physiology of bacteria. So first we'll start, what are the differences between your prokaryotes and eukaryotes? Okay, so your bacteria comes under prokaryote. So we'll learn about the differences of prokaryote and eukaryote. Prokaryotes are unicellular. Your eukaryote are multicellular, and they lack nuclear membrane. Prokaryotic organism doesn't have nuclear membrane, poorly defined due to absence of nuclear membrane. Eukaryote has well-defined nuclear membrane. Nucleolus is absent in prokaryote, which is present in eukaryote. Other organelles like mitochondria, Golgi body, these all are absent in prokaryote, which will be present in your eukaryote. Bacteria and blue-green algae comes under prokaryote. Fungi, plants, other animal cells comes under eukaryote. So question has been asked, which are the prokaryotes? So the answer was your bacteria and blue-green algae are prokaryote. So this was asked in PGI around 5-7 years back. This question was asked. The answer, PGI, we get multiple correct answers. So the answer was bacteria and blue-green algae. Okay. Now coming to resolution of light microscope. Please remember, resolution of light microscope is 300 nanometer. We know the type of microscope. We have light microscope, we have phase contrast microscope. Okay. Then we have dark ground microscope or dark field microscope. Then we have electron microscope and fluorescent microscope. Okay, so coming to resolution of light microscope, which is 300 nanometer. Dark ground microscope. Dark ground microscope demonstrate the flagella. Flagella is a organ of locomotion of bacteria. To become motile, the bacteria has to have flagella. Okay. So dark ground microscope is used to demonstrate motility of bacteria or to see visualize flagella of bacteria. So this year you had a NEET question, right? Related to Treponema pallidum, where you visualize this bacteria. So the answer is your dark ground microscope. Then fluorescent microscope, you use fluorescent dye. Fluorescent dyes are auramine and rhodamine. Negative staining. Negative staining when your background has stained. Okay, your background has taken stain, but organism has not taken stain. So that is your negative staining. Okay. Example for negative staining is your India ink. India's ink, which we use for capsular staining. So that also has been asked previously, which negative staining or which staining which we do to demonstrate capsule of the bacteria. So India ink, your capsulated organism like your Streptococcus pneumoniae, Klebsiella pneumoniae, Cryptococcus, you have to demonstrate the capsule with the help of India ink. So which takes stain? The organism doesn't take stain, your background takes the stain. Now coming to what are the differences between the cell wall of your gram-positive and gram-negative bacteria, right? Because the property of gram-positive and gram-negative differs. That is because of their cell wall difference and few other differences apart from cell wall. So peptidoglycan layer, both have peptidoglycan layer, but gram-positive have much thicker peptidoglycan, 60 to 80 nanometer than gram-negative, which has 2 nanometer. Because of this thicker peptidoglycan, they take the gram stain and does not lose. Okay, so they take the crystal violet or methyl violet, gentian violet, so they appear violet in color. Okay, because of thickness of their cell wall. Now coming to lipid content. In gram positive, it's almost negligible or nil lipid content. In gram negative, you have lipid around 50 to 20%. Lipopolysaccharide will be absent in gram positive, which we say LPSL. So we say lipopolysaccharide, which is present in gram negative. The endotoxic property, endotoxin production in gram negative is because of this lipopolysaccharide. Now teichoic acid present in gram positive, absent in gram negative. Aromatic amino acid, which is present in gram positive, absent in gram positive, present in gram negative. Porins are absent in gram positive. Porins are present in gram negative. Okay, so this has been asked. What are the teichoic acid, where it's present? Gram positive. Porine, where it's present? Outer membrane of gram negative bacteria. So this is the picture of your gram positive bacteria, and this is the picture of your gram negative, which has lipopolysaccharide layer. Now, how the flagella? Flagella is the organ of locomotion of bacteria you need for the motility of the bacteria. So how many types of flagella is there? The bacteria who doesn't have flagella, we say it as a atrichous. So this is atrichous, okay, which has single flagella at one end. We say it as a monotrichous. So it has been asked, bacteria with single flagella at one end is called as various option. So correct answer was monotrichous. Where we see monotrichous flagella? So we see in Vibrio cholera, we see in Pseudomonas, we see in Campylobacter. So Vibrio cholera, Pseudomonas, and Campylobacter has monotrichous flagella. Lophotrichous, where tuft of flagella is present at one end, which we see in Spirillum. Peritrichous, which we see in Salmonella typhi or Escherichia coli. This is the example for your, okay, peritrichous. Throughout the body, the flagella is present. So that is called peritrichous, which we see in Salmonella typhi or Escherichia coli. When flagella is present at both ends, we say it is an amphitrichous. Amphi means both. So both end flagella, amphitrichous, which we see in Alcaligens fecalis. Okay. So please remember, monotrichous, single flagella at one end, lophotrichous, tuft of flagella at one end, peritrichous, flagella present throughout the body, amphitrichous, tuft of flagella at both ends. Amphi means both. Okay. Now, which all are capsulated bacteria? That also has been asked previously. So just remember pneumococcus, meningococcus, Haemophilus influenzae, Klebsiella pneumoniae, Pseudomonas aeruginosa, Bacteroides fragilis, Bacillus anthracis, Streptococcus pyogenes. So these can be capsulated bacteria. Okay. So most of these bacteria, their capsule is polysaccharide in nature. Few exception is Bacillus anthracis, where capsule is polypeptide in nature. In Streptococcus pyogenes, it is hyaluronic acid. Okay, so all has polysaccharide capsule, but you have polypeptide capsule in Bacillus anthracis. Please remember the name of capsulated bacteria, which has been asked previously. Which of them are capsulated except? Now coming to bacterial growth curve, the plenty of question has been asked previously on bacterial growth curve. So this is the bacterial growth curve, number of bacterial cell and time. So this is your lag phase. Lag phase, then you have log phase, then you have stationary phase, and you have decline phase. Okay. So lag phase is the phase where bacteria adapts to new environment. Okay. And they attain maximum size. Okay, adjustment to environment, all protein and other things, substance synthesis happens in lag phase. They prepare themselves, okay, and they become bigger in size, but number does not increases, size only increases. Then you have log phase, which is exponential phase. Bacteria divide and number increases. Then you have stationary phase. Stationary phase is the phase where you see spore formation. Sporulation happens. All things will happen in stationary phase. Inclusion body formation. These all will happen in stationary phase. Log phase is the phase where bacteria takes gram stain very well. Other phase also bacteria takes, but stationary and all, they won't be uniformly stained. In log phase, bacteria gets uniformly stained with your gram staining. Okay. Decline phase is the phase where you see involution forms. Okay, L forms and other are involution forms. That involuting forms you see in a phase of decline. So you have lag phase where bacteria prepare themselves to external environment. Log phase where they divide maximum, and stationary phase where spore formation or inclusion body formations, polymetaphosphate formation will happen in stationary phase. Decline phase where involuting forms will form, L forms and other forms will form. So on the basis of temperature, how we divide the bacteria, what all terms we use. Psychrophile, which grow best in less than 20 degrees centigrade. That is, the example is your Pseudomonas. Mesophile, which grows as 25 to 40 degrees centigrade. So most of your pathogenic bacteria comes to this group of mesophile, 25 to 40 degrees centigrade. Thermophiles, which takes higher temperature, 55 to 80 degrees centigrade. That is your Geobacillus stereothermophilus. Okay, psychrophile less than 20, mesophile 25 to 40, thermophile 55 to 80 degrees centigrade. Now coming to molecular method, what all molecular techniques which we use in microbiology, right? The molecular techniques are more in a picture after the HIV outbreak, COVID outbreak. The molecular method has gone very significance, very high significance. So molecular method, you have PCR, polymerase chain reaction. You have real-time PCR, you have loop-mediated isothermal amplification, which is LAM. Then you have biofire film array, which is called multiplex PCR. Then you have CBNAT, which is cartridge-based nucleic acid amplification. So in PCR, 3 steps is there. Okay, you denature the DNA first. So first will be your denaturation, which happens at higher temperature. That is, you do at 95 degrees centigrade temperature. Denaturation. Then you will have next step, annealing. Annealing happens at the temperature of 62 to 65 degrees centigrade. Okay. Annealing where primer comes and start binding to the strand. Then extension, where DNA polymerase start extending the the fragment of DNA, that is extension, that will happen around 55 degree centigrade. So you have PCR denaturation, annealing, extension. Okay. Then what other microbial typing technique you have? You have phenotyping technique, you have genotyping technique. Please remember these all are probable question, because in microbiology, the molecular diagnostic technique has taken very high importance. So what are the phenotypic method? You have bacteriophage typing, which we do for Salmonella, Staphylococcus, and Vibrio cholera. Bacteriocin typing, which we do for Shigella soni and Pseudomonas. Biotyping is done for Corynebacterium diphtheriae and Vibrio cholera, which you have Altor and classic variant. So that is your biotyping. Then you have antibiogram typing, which is practiced in hospital infection control. Then serotyping, like your Streptococcus Lancefield classification is based on serotyping. So phenotyping, you have bacteriophage, bacteriocin, biotyping, antibiogram typing, and serotyping. In genotyping, you have restriction, fragment, length, polymorphism, RFLP. Then you have ribotyping and pulse gel electrophoresis. Then you have sequencing also. You have sequencing technique to know the whole sequence. You can do whole sequencing, whole genome sequencing to look for any mutation in the bacteria. Thank you.
Okay, we shall start. So another INICET 2021 likely question topic: indices in forensic medicine, right? Indices in forensic medicine, right? Okay, the next slide, please. So I've designed this session in such a way that it will have two sessions, today and tomorrow. In these two sessions, I'll cover all the indices with respect to forensic medicine, right? All the indexes, ratios, and all, right? So one of the most important topics. Yes. Okay. Next slide, please. So at the outset, you should know two terminologies. One is morphometry, right? Morphometry is measurement of dimensions, right? Any dimension. So morphometry is common to all species, all animals, right? It is common to human as well as animals. Morphometry. So morpho means measurement of dimensions, right? Dimension. Other terminology is anthropometry, right? Anthropometry. See, anthropometry is measurement of proportions of human body, right? Proportion of human body. So anthropometry means proportion with respect to body, right? Proportion with respect to body. See, one such anthropometric technique that is widely known to us is Bertillon system. Now, this Bertillon system is a GPMR question. The GPMR question is, which of the following techniques is an anthropometric technique, right? The answer is Bertillon system of anthropometry. So I'll tell you again: morphometry, dimension, right? Measurement of dimension, morphometry. Now anthropometry is measurement of proportion, body proportion, right? Body proportion. So example is Bertillon system. Yes. So next slide, please. So applications of morphometry. See, again, with the help of morphometry, what can we find? See, only three options are there, so we have to be careful. We can find species. So you have a bone, or you have a body. See, with the body, you measure a proportion or width a skeleton, you measure a proportion. This is morphometry. So with the morphometry, what can we achieve? With the help of morphometry, we can find species, we can find race, right, or ethnicity, right? Nowadays, the word ethnicity is used. Older textbooks will say race. So remember, species, race, bar ethnicity, and third one is sex of an individual, right? Sex of an individual. Only three. So these three means you have to be very careful, very potential for being asked in an MCQ. So species, race, and then sex, right? Yes, applications of morphometry, right? Now we'll go to the next slide. So next slide, please. So indices to find race, indices to find race. So now there was a question 2 years back with respect to AIMS. The question is, which of the following index is not useful to find race? Right? The question is, which of the following index is not useful for finding race? That is a question. So now we'll come back to the slide. I'll tell you what are all the indices or index useful to find race of a particular individual. So one is cephalic index. The most important is cephalic index. We'll see in detail about it. So cephalic index, facial index, brachial index, crural index, intermembral index, humerofemoral index. Just remember the words: cephalic, facial, then brachial, crural, intermembral, humerofemoral. Right? See, only six to find race. Only six. So cephalic, facial, brachial, crural, intermembral, and humerofemoral index. So we'll see one by one. All right. See, next slide, please. So first is cephalic index, right? Cephalic index, also called as Ritzius index. Now, one MCQ was, which are the following is called Ritzius index, right? So easy, straightforward question. If we are so lucky or fortunate, we have the straightforward question. Another name for cephalic index is Ritzius index, right? Ritzius index, right? So the index takes into account, the numerator is maximal breadth of the skull. So maximal breadth, right? So the numerator is breadth. Hence, cephalic index is also called as breadth index of skull, right? Breadth index of skull. So cephalic index, Ritzius index, or breadth index of skull. Now, maximal breadth of the skull divided by maximal length of the skull. The formula is maximal breadth divided by maximal length into 100. So please remember this into 100. I'll tell you there is one more MCQ, that is, which are the following indices doesn't use the multiplication factor 100? Now, that was one MCQ, right? 3 years back. Which are the following indices doesn't use the multiplication factor 100, right? So today I'm going to tell you the indices that use multiplication factor 100, right? It is easy to remember, right? So coming back to cephalic index, maximal breadth by maximal length into 100, right? So the first is, if the value is between 70 to 75, the skull is called dolichocephalic skull, right? Dolichocephalic skull, dolicho, right? Now, if the number is between 75 to 80, it is mesatecephalic. And if the number is 80 to 85, it is brachycephalic. See, just understand the logic. Maximal breadth is the numerator. Maximal length of the skull is the denominator. So as long as the skull is shorter, brachy means short, right? Brachy means short. If the length is decreased, the value, the cephalic index will be higher, 80 to 85, higher value. So brachycephalic, right? Brachycephalic. So I'll tell you again: 70 to 75 dolichocephalic, 75 to 80 mesatecephalic, 80 to 85 brachycephalic. Now the question here is, so these dolichocephalic, mesatecephalic, or brachycephalic would fit into which race, right? Which race? Now answer is D. Remember, D is for Dravidians, Aryans, Negroids, right? Dolichocephalic fit into Dravidians, pure Aryans, and Negroids, right? Yes. Then mesatecephalic fits into Chinese, right? Chinese. Mesatecephalic, Chinese. Then brachycephalic is Mongols and Japanese. So next animation, please. So I'll tell you again: dolichocephalic belongs to Dravidians, Aryans, Negroids. We can say aborigines also, natives, aborigines, right? Then mesatecephalic for Chinese, brachycephalic for Mongols and Japanese. So please remember, cephalic index is often repeated MCQ with respect to INICET. Often repeated MCQ, right? Cephalic index, also called as Ritzius index or breadth index. The value is 70 to 75. Dolichocephalic, Dravidian, Aborigine, Aryan, Negroid. If the value is 75 to 80, Mesocephalic, Chinese. The value is 80 to 85, brachycephalic, Mongols or Japanese, right? We'll go to next slide. Next slide, please. So in this slide, so just know the formula. Number is not mandatory for this index. Number is asked only for cephalic index. Other indices, just know the formula. That is enough, right? So second index to find race is facial index. Facial index, right? Facial index. See, facial index is nothing but the distance between nasion to gnathion, right? Chin. Nasion to gnathion. So the maximal distance between nasion to gnathion, numerator. And the denominator is zygomatic distance, right? Maximal facial width. This other is called as maximal facial width, right? So the numerator is the distance between nasion to gnathion, and the denominator is zygomatic distance, right? Zygomatic distance, right? So we'll go to the next slide. Next slide, please. Yes. So other indices to find race, right? So first is cephalic index, second is facial index. Now other four indices are brachial index, crural index, intermembrane index, humerofemoral index. So now how do we calculate brachial index? Brachial index is nothing but just look at the word brachial. R comes first. Remember this way, R comes first in brachial, BR. So R, right? R comes first. Length of radius, maximal length of radius divided by maximal length of humerus, right? Into 100, right? Into 100. See, all indices to find race have multiplication factor 100, right? All six indices to find race will have multiplication factor 100, right? So brachial index is maximal length of radius divided by maximal length of humerus into 100, right? So if you remember this, you can fill the next. Crural index is maximal length of tibia divided by maximal length of femur, right? So maximal length of tibia divided by maximal length of femur. Now, third one, intermembral index. Intermembral index is nothing but you have to add radius and humerus in the numerator. Maximal length of radius with maximal length of humerus in the numerator. The denominator has maximal length of tibia plus femur, right? Maximal length of tibia plus femur into 100, right? Intermembral index. And humerofemoral index is so easy. Length of humerus divided by length of femur, right? Length of humerus divided by length of femur into 100. So shortly, the animation, please. So I have made a box here. Maybe have the animation, please. So brachial index, R by H, maximal length of radius by humerus. Crural index, tibia by femur. Intermembral indexes, you have to add radius plus humerus divided by tibia plus femur. Now humerofemoral index is nothing but length of humerus divided by length of femur. So animation, please. Yes, so you can see the box, right? Please remember, I'll tell you again, brachial index, first R comes with respect to the word brachium, R comes first. So radius comes the numerator, right? Then humerus. So if you remember one thing, you can deduce the other things, tibia by femur, right? For brachial and crural index, right? Intermembral index is easy. You have to add, it is nothing but ratio of upper limb to lower limb. You can remember this way, ratio of upper limb to lower limb, right? Tentatively, you can remember that way. So you have to add radius plus humerus and then divide by tibia plus femur, right? Yes. Then humerofemoral index, I told you. So out these four indices, it is enough if we know what is the numerator and denominator, right? Okay. So we'll go to the next slide. Oh, next slide, please. So other, see, these are not indexes. I'll tell you, these are not indices, but they are often repeated MCQ with respect to race. With respect to race, they are often repeated MCQ, right? If you see the word nasal gutter, see, the question will be in such a way that a skull was recovered from a deserted area. The skull has so-and-so cephalic index with the following features, right? If you see the word nasal gutter, nasal gutter. The race is negroid. Straight away you can say nasal gutter negroid. Right? Nasal gutter is unique to negroid race. Please remember, nasal gutter. Right? One clinching point for negroid race is nasal gutter. Right? Nasal gutter. Right? So the nasal cavity will be, if you take the skull, in the nasal area, there will be a gutter-like uh, trait, right? Gutter-like trait. Gutter is nothing but a drainage pathway, right? It is called pathway. So gutter will be a huge pathway like uh, dip in the nasal area. So nasal gutter, negroid, right? Negroid. So additional features will be hyperbolic dental arch and a rectangle orbit, right? Rectangle orbit for negroid, right? So for Mongols, shovel incisors, right? I'll show you the photo, huh? You would understand. Then elliptical dental arch, right? Elliptical dental arch, right? And third one is caucasoid. See, remember caucasoid C for carabolic cusp C. So carabolic cusp, right? Carabolic cusp is present in caucasoid race. Often repeated MCQ. Carabolic cusp is seen in caucasoid race. Nasal gutter, negroid. Shovel incisor, Mongol, right? Often repeated MCQ. Straightforward questions, so easy, right? Straightforward questions, so easy. So I've given the shape of dental arch, right, in the animation form. You can see it. So I tell you again, Carabolicus, caucasoid. Never forget, shovel incisor, Mongol, nasal gutter, negroid. So we'll go to the next slide. Next slide, please. Yes. So next slide, you see, this is a shovel used for digging, right? Digging, the shovel on the right side. Now the incisor, if you look at the incisor, the inside surface, right? The inside surface will look exactly like the shovel, right? Exactly like the shovel. It is called shovel-shaped incisor, right? Shovel-shaped incisor. Now there is a different question, a different wording you can say. In PGI, there was a question, double shovel incisor. See, shovel shaped incisor, we know, right? Double shovel shaped incisor, the same thing, nothing but the shovel shape will be present even on the anterior aspect also. Now what we are saying is posterior aspect of the incisor. In the posterior aspect, see, the shovel shaping is more common in posterior aspect. We can see shoveling only on the posterior aspect of incisor teeth. If it is rarely seen on the anterior aspect also, it is called double shovel shaped incisor, right? So shovel shaped incisor, Mongol, right? So shovel shaped incisor, Mongol, right? So we'll go to the next slide. So next slide is indices to find sex. So far we have completed indices to find race, right? Indices to find race. I tell you again, cephalic index was there, facial index was there, right? Brachial, crural, intermembral, humerofemoral. 6 indices were there. So we saw 6 indices. Now we are going to the second application. Second application is to find sex of an individual. To find sex of an individual. So we'll see first 3, right? We'll see only the first 3 alone today. The remaining and the miscellaneous indices we'll see tomorrow, right? So first 3, we'll concentrate only on the 3 most important and most repeat MCQs in the first 3. We'll see that. So kylotic index, sciatic notch index, ischiopubic index, right? So we can remember with the mnemonic CSI, Church of South India, CSI, kylotic line, right? Sciatic notch, ischiopubic, CSI, right? CSI, as of now. And the second is SAC we remember, right? So we'll see the first 3, kylotic line, sciatic notch, ischiopubic indices, right? So the next slide, please. On the next slide, yes. So we have all 3 indices here. So I'll tell you one by one. The pictures clearly indicate, see the blue background picture, the kylotic line index. See, the kylotic line index is nothing but maximal length of pelvic segment of kylotic line divided by sacral segment of kylotic line. See, please follow me. Kylotic line index is nothing but you have to measure the kylotic line. So now, where is the kylotic line? The kylotic line indicated by the black line. You see, the black line is the kylotic line. See, kylotic line is nothing but an extension of iliopectineal eminence. So from iliopectineal eminence and from the iliopectineal line, you have to draw a line. So there is an anatomical ridge. It is nothing but an anatomical ridge. It is an anatomical ridge, no imaginary line. It is an anatomical ridge. There is a kylotic line. So from the continuation of iliopectineal line. So you have to start from the iliopectineal eminence. So the line with the black line is the sacral, sorry, for the pelvic segment of kylotic line. So first is pelvic segment of kylotic line in the numerator. So if you draw the pelvic kylotic line, the kylotic line starts from iliopectineal eminence and it ends in auricle, right? This is a pelvic segment. Now from the auricle, extend the line to iliac crest. Extend the line to iliac crest, right? So kylotic line, extension of iliopectineal line, we know from iliopectineal eminence to auricle, that is pelvic segment of kylotic line. Second is from the auricle, extend the line to iliac crest, right? Iliac crest. See, you have to remember pelvic segment, bisacral segment of kylotic line, where it starts, where it ends, right? Pelvic segment starts from iliopectineal eminence to auricle. Sacral segment starts from auricle to iliac crest, right? So this is kylotic line index, right? Now we'll go to sciatic notch index. See, sciatic notch index is nothing but D. It starts with D. Depth of sciatic notch, right? Depth of sciatic notch, right? Depth of sciatic notch. See, depth of sciatic notch divided by maximal breadth of sciatic notch, right? Maximal depth divided by maximal breadth, right? Sciatic notch index. So maximal depth divided by maximal breadth of sciatic notch into 100, of course, right? Yes. Kylotic line index, sciatic notch index, and ischiopubic index will have multiplication factor 100, right? Yes. And then last one is ischiopubic index, right? Ischiopubic index. Please remember, this ischiopubic index is otherwise called as Washburn index, right? Washburn index. Name of the anthropologist, Washburn. So ischiopubic index is length of pubis divided by length of ischium, right? Length of pubic bone by length of ischium bone into 100, right? Into 100. I'll tell you one important point with respect to ischiopubic index. Ischiopubic index is used to find sex of an individual. Even in utero, even in fetus, you can find sex using ischiopubic index. One. Second is ischiopubic index is useful to identify species, right? Ischiopubic index is so unique in anthropology because ischiopubic index is used to find sex. That is the primary objective. Ischiopubic index to find sex. Additional is with respect to ischiopubic index, you can find species also. So kylotic line index, sciatic notch index, and ischiopubic index. All three will have a multiplication factor 100. Oh, right. So with this, we'll close today, and tomorrow we'll complete the indices for sex and other miscellaneous indexes with respect to forensic medicine. Right. Thank you.
Yeah, is the screen seen? Yeah. So, yeah, is the screen seen? Am I audible? Yeah. So we'll start the gaze palsies today. So today we are left with gaze palsies, and tomorrow we'll finish the cranial nerve palsies. With that, we will finish neuro-ophthalmology. Okay. So the important gaze palsies we should know. Okay. So before that. So before we enter the gaze palsy, as I discussed yesterday, the third order neuron, it leaves the lateral geniculate body to go to the visual cortex. So the lateral geniculate body, it has two pathways, the magnocellular pathway and the parvocellular pathway. So the magnocellular pathway is formed by the 1 and 2 layers of the lateral geniculate body. So the lateral geniculate body, the 1 and 2 layers form the magnocellular pathway. They detect the motion at point-to-point discrimination. The parvocellular pathway is formed by the layers 3 to 6. They are responsible for color. Okay. So magnocellular pathway and the parvocellular pathway are divided into 6 layers. The lateral geniculate body is divided into 6 layers. The first 2 layers form the magnocellular pathway. 3 to 6 form the parvocellular pathway. We have to remember again, some of the layers, the fibers from some of the layers cross over. So which are the important layers which cross over? M1 from the magnocellular pathway, and from the parvocellular pathway, it is the P4 and P5. Okay, so P4 and P5 are crossed over while the remaining are on the same side. Okay, so this is the lateral geniculate body. Next, we go to the horizontal gaze center. Okay, so remember, which is the horizontal gaze center? Yesterday we discussed the horizontal gaze center is the parapontine reticular formation. The parapontine reticular formation, it receives information from the international neurons of the MLF. Okay, MLF stands for the medial longitudinal fasciculus. So any lesion of the medial longitudinal fasciculus will result in a condition called as internuclear ophthalmoplegia. So any lesion of the MLF will result in a internuclear ophthalmoplegia. So what are the features of a patient with INO? So a patient having a right-sided lesion of the MLF will have a right-sided abduction deficit. So there will be an ipsilateral abduction deficit with a contralateral, ipsilateral adduction deficit. Ipsilateral adduction deficit and contralateral abduction nystagmus. Contralateral abduction nystagmus. I'll repeat again. So a patient having a lesion of the MLF will have an internuclear ophthalmoplegia. For a patient having a right-sided MLF lesion, having a right-sided INO, there will be defective adduction of the right eye and an abduction nystagmus in the left eye. Okay, this is the feature of a internuclear ophthalmoplegia. Okay, so so this is the representation. So here we can see the impulses from the medial rectus are transmitted via the third cranial nerve to the medial longitudinal fasciculus. So from the medial longitudinal fasciculus via the international neurons, it goes to the parapontine reticular formation. So the parapontine reticular formation forms the horizontal gaze center. So from the parapontine reticular formation via the abducent nerve, the impulses are transmitted to the lateral rectus. Okay, this is how the horizontal gaze center is under regulation. So the PPRF is under the direct control of the contralateral frontal lobe. Remember, the PPRF is under the direct control of the contralateral frontal lobe. So this is how the frontal lobe exerts its control over the horizontal gaze. Okay, so we discussed about INO. So next we have to know something about, so this is INO. Okay, so what are we seeing here? So this patient, note that the adduction deficit in the right eye. So whenever the patient, the right eye is trying to adduct. Okay, when the patient is trying to adduct in the right eye is not able to adduct, and there is an abduction nystagmus in the left eye. There is an abduction nystagmus in the left eye. So this is the patient with a right-sided INO. So INO is again named after the side in which there is an adduction deficit. So if the patient has adduction deficit of the right eye, it is a right-sided INO. If the patient has an adduction deficit of the left eye, it is a left-sided INO. Okay, so the side in which there is the adduction deficit is the side of the INO. Okay, so this is another important point. Okay, so we should know about the important etiology or causes for INO. So the most common cause is the infarction of the brainstem. Then demyelination, mainly or multiple sclerosis, can result in internuclear ophthalmoplegia, tumors, infection, hydrocephalus. So main thing you'll have to remember is the top three. Okay, so the patient will have a horizontal diplopia. The patient will have difficulty in tracking the fast moving objects and also a vertical oblique diplopia. So the signs include the adducting saccades, limiting adduction in one eye, and abduction of the fellow eye. When the patient is abducting the fellow eye, there is a nystagmus in the fellow eye. Very important point to remember is that the convergence is present. So in a patient with INO, when you check for convergence, the convergence is present. Convergence is normal. So this is another very important point differentiating INO from the other lesions. Convergence is retained or preserved in INO. Vertical gaze palsy may be present. Okay, so what is the investigation for any demyelinating disorder or infarction? Again, MRI is the investigation of choice, and whatever is the cause, you have to treat the underlying cause. If it's a demyelination, treat multiple sclerosis. If it's a tumor, do a surgery for the tumor. Okay, so the treatment will vary based on the case. Okay, so next we have something called as 1.5 syndrome. So what happens in this 1.5 syndrome? There is the involvement of the ipsilateral PPRF, there is involvement of the ipsilateral MLF, and there is involvement of the 6th cranial nerve. Okay, so there is involvement of PPRF, there is involvement of MLF, there is involvement of the sixth cranial nerve. So, sixth cranial nerve. So what is the only movement a patient with 1.5 syndrome will have? The only movement in a patient with 1.5 syndrome is a contralateral abduction. So contralateral abduction is the only movement the patient will have. Okay, to repeat, 1.5 syndrome is due to the lesion of the PPRF, MLF, and the ipsilateral sixth cranial nerve. The only movement the patient will have is the abduction of the contralateral eye. Next, we have something called as 8.5 syndrome. What is 8.5 syndrome? 8.5 syndrome is 7th cranial nerve involvement along with 1.5 syndrome. So the patient will have an ipsilateral nuclear level 7th cranial nerve palsy along with 1.5 syndrome. So the patient having ipsilateral 7th cranial nerve palsy along with 1.5 syndrome is your 8.5 syndrome. Okay. So this is mentioned in your ophthalmology, neuro-ophthalmology book called as Walsh and Hoyt. Okay, this is from Walsh and Hoyt. So mainly you should know about internuclear ophthalmoplegia. You can expect questions from internuclear ophthalmoplegia. Also 1.5 syndrome, the only movement left in the patient is the contralateral abduction, and 8.5 syndrome. 8.5 syndrome is 7th cranial nerve with involvement of the 1.5 syndrome. Okay. So we discussed about the horizontal gaze center. Now coming to the vertical gaze center, remember I told you the vertical gaze center is the rostral interstitial medial longitudinal fasciculus, rostral interstitial nucleus of the MLF, and the interstitial nucleus of Kajal. Interstitial nucleus of Kajal and the rostral interstitial MLF nucleus is the vertical gaze center. This also they have asked many number of times. Okay, so the vertical gaze center is nucleus of Kajal along with the RI MLF. Okay, so next we have to know about the vertical gaze palsy. Okay, so vertical gaze palsy can be caused by any midbrain tumor. It can be caused by Parkinsonism. It can be caused by progressive supranuclear palsy and lipoidosis. Okay, so we'll mainly discuss about the Perinaut syndrome. Perinaut syndrome is the dorsal midbrain syndrome which has a supranuclear palsy. The patient will have a supranuclear palsy. In the primary gaze, the patient is able to see normally. Downward gaze is normal, but elevation is abnormal. In this patient, typically elevation is abnormal, and elevation is associated with upper lid retraction. The upper lid retraction present in a patient with Perinaut syndrome is known as the Collier sign. The upper lid retraction is present. The patient will also have a large pupil with light near dissociation. The patient will have a large pupil with light near dissociation. Also, one more important thing you have to remember is that the patient will have a convergence weakness and a convergence retraction nystagmus. The convergence in these patients are weak. So this is how you, what did I tell you previously? In INO and in your internuclear ophthalmoplegia, the convergence is normal. But in a patient with dorsal midbrain syndrome or a Perinaut syndrome, the convergence is weak. So whenever the patient tries to converge, there is a convergence retraction nystagmus. This is another characteristic feature of the Perinaut syndrome. So supranuclear gaze palsy, light near dissociation, convergence weakness, convergence retraction nystagmus, and upper lid retraction, also known as Collier sign. So these are the features of Perinaut syndrome. Perinaut syndrome, you have to remember what are the important causes in children, what are the important causes in adults. Okay, so in children, first thing you have to remember is aqueduct stenosis, meningitis, and pinealoma. In adults, mainly your demyelinating causes such as multiple sclerosis, trauma, and atriovenous malformations are important causes. And very elderly people, again, your vascular accidents and posterior fossa aneurysms are the common cause for Perinaut syndrome. Next, we go to Marcus-Gunn jaw-winking syndrome. What is Marcus-Gunn jaw-winking syndrome? So this is a type of disorder wherein whenever the patient opens his mouth or moves the jaw sideward, there is an upper lid retraction. Okay, so patient will have a congenital ptosis. So the ptotic eye will retract whenever the patient will move the jaw. Either the patient opens his mouth or the patient will move the jaw side by side. Okay, this is because of the stimulation of the ipsilateral pterygoid. So the nerve supplying the levator palpebral superior has a abnormal innervation to the ipsilateral pterygoids. Hence, whenever the patient will move the jaw, either while opening the mouth or sideward jaw movements while chewing, there will be an upper lid retraction, which is known as the Marcus-Gunn jaw-winking syndrome. Okay, so next we go to the questions. So on T2 weighted MRI, which will appear hyperintense. So okay, so you should know about the appearance in T1 weighted MRI and T2 weighted MRI. Okay, so directly we'll go to this one. So remember, fat and vitreous are opposite to one another in both T1 and T2. So this is the main thing you have to remember. Okay. So fat and vitreous are exactly opposite in T1 and T2 weight images. Okay. So this is the table showing the T1 and T2 weight images. So remember, vitreous is hyperintense on T2. Vitreous is hyperintense on T2. What did we tell? Fat is hyperintense on T1. Okay. So T1 it is fat. Vitreous is T2. Vitreous aqueous is again T2. And also any cysts. Okay. CNS cysts is hyperintense on T2. Okay. So from ophthal point of view, remember the T1 weighted images, the orbital fat is more prominent. In T2 weighted images, the vitreous is more prominent. Okay. The vitreous is more prominent in T2 weighted images, and T1 weighted images, the fat is more prominent. Okay. This is very important. So this will help you identify what is the pathology. Okay. So next question. The patient shown in figure 4.16 has a normal vertical movement. The left eye develops a jerk nystagmus on attempted left gaze. Where is the most likely location of the causative lesion? Okay. So when we see the right gaze, that extroversion is normal in this patient. While when the patient is primary position again is normal, when the patient is trying to do the levoversion, the left eye is abducting normally, but the right eye is not adducting. So what did I tell you? In INO, the side of the lesion is the side of the INO. So the patient has a right-sided adduction deficit. The patient has a right-sided INO. So the involvement is again right-sided medial longitudinal fasciculus. Okay. So the involvement is in the right-sided medial longitudinal fasciculus. So I told you there is a adduction deficit and a contralateral abduction nystagmus. Very important point is convergence is normal. Remember in INO, the convergence is normal. Whereas in Perinaut syndrome, the patient will have a convergence weakness and a convergence retraction nystagmus. Which of the following is not involved in vertical eye movement? So just now we just discussed the PPRF is the horizontal gaze center. So PPRF is not involved in the vertical eye movement. The interstitial nucleus of Kajal, the trochlear nerve again supplies the superior oblique, which is involved in the vertical eye movement, which is involved in intorsion, which is a vertical movement, and the frontal lobe is also involved. Okay. So the vertical gaze center is the RIMLF and the interstitial nucleus of Kajal. PPRF is the horizontal gaze center. Okay. So with this, we will finish the class today. Hopefully, most of you have done well. Your NEET results are out. Okay. So hopefully you've come out with flying colors. So those who are preparing seriously, I would advise you, despite the results, continue with your INI-CET preparation. And we will see you tomorrow with the 3rd, 4th, 6th cranial nerve pulses. So tomorrow we'll finish neuro-ophthalmology. Day after tomorrow, we are going to start with retina. Okay. So with this, I stop the class.
Good evening, students. Let me share the screen. Okay, so today we are going to see a very important. Today we are going to see a very important topic. We can expect the question, which I am expecting for a long period of time, and it may come. So the question will go like this. This is a plot that is given in the exam, and the question will go like this. So the following studies not fit the evidence. Okay, you can see there are a lot of studies that has been plotted here. You can see that there are a lot of studies has been plotted here. We have the one study. A minute. We have a study here with et al, and the line is given and the odds ratio is given with the odds ratio is given and the bracket some values are given. So this is the next study is given, the confidence interval, odds ratio and confidence interval. So they are asking the question. They're asking the question, which of the following studies not fit the evidence? Okay, so the question asked is the very clear about this is the word evidence is asked. So what do you mean by the evidence? Evidence which they are telling. Okay. So the evidence which they are telling is the formed by, there are a lot of study designs. So this is called evidence pyramid. Evidence pyramid is what? Evidence, this is called evidence pyramid. Evidence pyramid. What is evidence pyramid? In the study design, which study design gives the best evidence, that is best causes for this thing, that is called evidence pyramid. In that we have various study designs, and you can see that topmost is occupied by meta-analysis. The topmost is occupied by meta-analysis and followed by double-blinded RCT, then cohort study, case control study, longitudinal study, cross-sectional study, ecological study, case series, and case report. So what is case report? Case report means only one case is reported. Case series is multiple cases are reported. Multiple cases are reported. Okay. So the evidence-based pyramid is coined by a scientist called David Socket. Okay. So in this, which gives the best level of evidence? Best level of evidence is given by meta-analysis. Okay. So in meta-analysis, we have something. Meta-analysis means what? Meta-analysis, again, I want to stress here. Meta-analysis is analysis of analysis. Okay, what is analysis of analysis? Already analysis has been done by someone. In that, I am doing another analysis. That is called meta-analysis. Okay. So this is in the meta-analysis, we have something called this. This is called forest plot. Okay, in meta-analysis, there is something called forest plot. So what is forest plot? Forest plot is the graphical representation of the studies. The graphical representation of the studies that has been done in meta-analysis. This forest plot will list what are the studies I have analyzed. This Smith et al. Is a study that I have analyzed. In that you can see something called OR, that is called odds ratio. Odds ratio is the analysis estimate. In that you can see there is something called diamond shaped thing in the meta-analysis. What does diamond shaped indicate? This indicates something called effect size. Effect size. What is effect size? The whole study's effect size odds ratio is this. Okay. Now we are going to discuss how to interpret an odds ratio. Okay. Okay. So you all know odds ratio more than 1 is positive association. Odds ratio equal to 1, no association. Odds ratio less than 1, negative association. Okay, so what I want to convey from that? Odds ratio more than 1 indicates positive association. Means, suppose I have a odds ratio, suppose I will tell two scenarios. Suppose I have odds ratio of 1.8 and the confidence interval becomes, okay, 1.5 to 3.5. Second, the odds ratio is 1.8, but the confidence interval is 1 to 4.2. Suppose odds ratio 1.8, but the confidence interval is 0.42 to 1.95. So in the first scenario, this odds ratio is more than 1, matlab means positive association. Okay, and this 1.8 is fit into the range of odds ratio 1.5 to 3.5. You see the lower limit of the confidence interval 1.5, it is more than 1, positive association. Upper range of the confidence interval 3.5, more than 1, positive association, fine. So it is a perfect odds ratio. I repeat again, odds ratio more than 1 is positive association. First, you have to see whether the odds ratio is fit into the range of the confidence interval. You have to see the lower limit, that is 1.5, which is a positive association. 3.5, that is more than 1, that is also a positive association. Next, you go to the second scenario, 1.8, it is more than 1, positive association, I understand. And it fit into the range, yes, correct, it's fit into the range, but you see the lower limit, 1. Lower limit is 1 is what? No association. 4.2 is positive association, but the lower limit is no association. So this is imperfect odds ratio. Okay. Now you see the odds ratio here, 1.8. Okay. And is it fit into the range? Yes, it's fit into the range, but the lower limit is 0.42. less than 1, negative association. So again, this comes under imperfect odds ratio. So this is the interpretation of odds ratio. First, step 1. Step 1 is determine the odds ratio. Step 2, see whether the fit in the confidence interval. Third, see the lower limit of the confidence interval and upper limit of the confidence interval. Okay, upper limit of the confidence interval. Okay, so this is the steps to interpret the odds ratio. So shall we go to the plot which we had put up. Okay, once again I will put up. So you see the first odds ratio, Smith et al. Done in 1991 is 1.1, 1.3. What is 1.3, students? Odds ratio more than 1 is positive association. Is it fit into the range? Yes, it fit into the range. But you see the lower limit of the confidence interval 0.5. So is it a perfect odds ratio? No, it is an imperfect odds ratio. Okay, though odds ratio is more than 1, but the both lower limit and the upper limit does not fit into the range of the positive association of odds ratio. So that is ruled out. Second scenario, Jones et al. 1993, 2.1. Odds ratio 2.1, is it a positive association and negative association? No association. It is positive association. Is it fit into the range of confidence interval? Yes, it is fitting. But you see the lower limit, 1 is no association. So again, it is an imperfect odds ratio. Third one, 1.8. 1.8, is it more than 1? Is it positive association, negative association, or no association? It is positive association. Is it fit into the range? Yes, it fit into the range. But you see the lower limit 0.9 less than 1, it is a negative association. So it is the imperfect odds ratio. Next, fourth one, 2.3. Is it fitting into the odds ratio? Yes, it is fitting. 2.3 is more than 1, it is a positive association. And you see lower limit 1.9, is it positive association? Yes, it is positive association. 2.7, it is a positive association. So it is a perfect odds ratio. So Young et al. Evidence I can take into the study. Okay, so you can see there is a square box. What is the square? The square indicates. Okay, the square indicates the odds ratio, and the line indicates the confidence interval. Okay, confidence interval. Okay, so this is a perfect odds ratio. And the fourth one, that is 2.1, it is fitting into positive association. It's fitting into that lower limit and upper limit is a perfect odds ratio. Okay, so what do you want to convey? This Young et al. And the Chu et al. Is providing the best fit into the evidence. There is one more way to predict the forest plot. With suppose this odds ratio is not given, then another way to interpret the forest plot is the confidence interval should not touch or cross this line. I told students this is a confidence interval line that should not touch or cross this one line. What I want to convey, if it is touches the one, that is no association. If it is crosses the one on the left side, that is called left shift, that is negative association. So again, this won't fit into the purpose. So we have to fit that. So we have to see that which one is the not touches the line or crosses the line. Okay, so let's come back to the question. Which of the following does not fit into the evidence? As per the answer, Smith et al. 1991, that study does not fit into the evidence because you know the odds ratio. Though odds ratio more than 1 positive association, but the confidence interval does not fit into the perfect odds ratio criteria. So we can omit the criteria. So the question that can ask in the forest plot is comes under meta-analysis. Number 1 point, it is a meta-analysis. Second one, it is a meta-analysis part. Second one, the diamond indicates what? The diamond indicates the effect size. Okay, that is another thing. Okay, so then how to interpret the odds ratio? We have to see the lower limit and upper limit of the confidence interval. Both should be more than 1. Okay, so this thing, then you have to thoroughly know about the evidence-based pyramid created by David Socket, which include meta-analysis, the highest level of evidence, which is analysis of analysis, followed by double-blinded RCT, the randomized control trial. Cohort study is again best level evidence. Cohort study is from the risk factor to the disease or cost to the effect. Okay. Case control study, okay, which is from the effect to the cause or disease to the risk factor. Retrospective study, cohort study is a prospective study. Longitudinal study is again a multiple cross-sectional study. Cross-sectional study is otherwise called prevalence study. Cohort study is an incident study. Just a recap of what we have doing. Okay, cohort study is incident study. Cross-sectional is a prevalence study. Ecological study, case is multiple cases reported. Case report is only one case reported. So this is how this is start today. We have read about the how to interpret the forest plot, which we can expect the this aims. Okay. So thank you so much for the students. Those who got NEET PG poor rank, please start to study again. Only just a step away to get a PG seat. You need only revision, revision, revision. If you the more you revise, faster you get PG seat. The less you revise, longer you get the PG. That's the concept of everything. Not only PG seat, every exam. So more you revise, faster you get the PG seat. Wish you all the best for the AIMS exam. Thank you.
Okay. Very good evening to all. So this is the third day in the series of the new concept of INI-CET which we are following. We will be discussing one topic with the help of one MCQ and preferably few more MCQs which can be asked in the similar topic. And we'll try to have a complete review of that topic so that the entire topic is understood by everyone and nobody falters in exams whenever this question is getting repeated again and again. So the topic of today is an infant of diabetic mother. So infant of diabetic mother is a very important topic when it comes to pediatrics, more so because it is associated with hell lot of complications, and infant of diabetic mother is an nidus for having so many abnormalities and pathologies which can be seen and which can be troubling the neonatologist as well as the baby, both in terms of the problems which can be seen in them. Not only there will be problems at the metabolic level, but also there will be problems at the level of major organs, and also there will be an element of what congenital malformations which you have to be aware of. So with this, we start with today's topic of infant of diabetic mother. We just go through the first question and try to see how well we can understand the topic of infant of diabetic mother. So here we have an infant of diabetic mother who is weighing 3.8 kilos. Remember, 3.8 kilos from an Indian point of view, it seems to be large for gestational age. But in what you call in absolute terms, if you want to call a baby who is newborn and is macrosomic, the birth weight should be more than 4 kilograms. So his birth weight is on the higher side. Now this baby is presenting with seizures after 16 hours of birth. Now the question is, what is the cause? Now, if you look into the options, the option A is hypoglycemia, option B is hypocalcemia, option C is birth asphyxia, option D is intraventricular hemorrhage. Now, if you look into the differential diagnosis of neonatal seizures, all four of them are associated with seizures. So, here we need to identify the best possible match for this question. So, the clues for this question would be that the baby is an infant of diabetic mother. He is macrosomic, and likely macrosomic, though the cutoff is not reaching that threshold, and he is having seizures, and that is at 16 hours of life. So the most common cause of seizure in an infant of diabetic mother is going to be hypoglycemia for all practical purposes. Though the infant of diabetic mother can be associated with hypocalcemia, there may be coexisting birth asphyxia or an intraventricular hemorrhage because of various reasons, but these four clues are going to provide that the differential diagnosis for this question would be hypoglycemia, because hypoglycemia has been found to be consistently associated with seizure. The onset of hypoglycemia can occur as early as 1 to 3 hours of life, and an RDR of around 45 milligrams per deciliter is soon achieved by around 16 hours when the patient starts developing seizures again. So the definition of neonatal hypoglycemia is very important. So what exactly is the definition of hypoglycemia? The definition of hypoglycemia involves a particular cutoff, and this particular cutoff is different for plasma glucose and different for blood glucose. So the blood glucose value of less than 40 milligram per deciliter or a plasma glucose level of less than 45 milligram per deciliter is considered to be definition of neonatal hypoglycemia. Always remember, though the patient satisfies the criteria for neonatal hypoglycemia, the patient, the neonate may need not be necessarily symptomatic. That means we have two types of hypoglycemia. One is a symptomatic hypoglycemia where the neonate is having symptoms because of hypoglycemia. Two is a hypoglycemia which is relatively asymptomatic. So if you look into those neonates who are presenting with symptomatic hypoglycemia, there is a lot of clinical manifestations of hypoglycemia which you can note in those babies, right from jitteriness, which is a seizure mimic, irritability, hypotonia, lethargy, high-pitched cry, hypothermia, poor suck, tachypnea, cyanosis, apnea, seizures, and cardiac arrest. All can be the manifestations of hypoglycemia. Now, in general, if you talk about the etiologies of hypoglycemia, we need to have the common etiologies first, which includes nothing but prematurity. So prematurity is one of the most common cause of hypoglycemia. This is followed by intrauterine growth retardations, small for gestational age, large for gestational age, perinatal asphyxia, hemolytic disease of newborn, neonatal sepsis, polycythemia, post-exchange transfusion, parenteral nutrition, and an infant of diabetic mother. From all these differential diagnoses, the point which is relevant to our question was an infant of diabetic mother with the setting of macrosomia, probably presenting at 16 hours of life with an episode of seizure. All these are pointing towards the hypoglycemia as a etiology. Hypoglycemia as a etiology. So the next question comes: how do I manage this patient with this baby with hypoglycemia? So the management of hypoglycemia depends upon whether the baby is symptomatic or asymptomatic. If the baby is having asymptomatic hypoglycemia, see how low is the blood glucose. Is it terribly low, less than 20 milligram per deciliter, or is it between 20 to 40 milligram per deciliter? Because the definition of hypoglycemia is a blood glucose of less than 40 milligram per deciliter. Now, if it is extremely low, then you need to have the baby started on glucose infusion. That is, dextrose infusion at the rate of 6 milligram per kg per minute is the solution for this asymptomatic hypoglycemia with a blood glucose level of less than 20 milligram per deciliter. You need to repeat the blood glucose after 60 minutes and titrate the glucose infusion rate. GIR stands for glucose infusion rate. If the blood glucose level keeps below the level of 40 milligram per deciliter, you will have to increase the glucose infusion rate from 6 to 8, 8 to 10, 10 to 12, depending upon the degree of hypoglycemia. If the baby is having asymptomatic hypoglycemia, every attempt should be made to give NG feeds or oral feeds in order to prevent conversion of a asymptomatic hypoglycemia to symptomatic hypoglycemia. Again, after giving the oral feeds, either to the NG tube or by Katori, what you are supposed to do is you have to repeat the blood glucose at the level after 60 minutes of giving oral feeds. If the baby is showing less than 40 milligram per deciliter of blood glucose, then at that point of time you need to start the infusion of dextrose. However, if the blood sugar is more than 40 milligram per deciliter, then you will have to chart 2 hourly feeds and monitor the blood sugars every 6 hourly for a period of around 2 days. So this is the management protocol of patients with asymptomatic hypoglycemia. Now, at any point of time during the course of management of a patient with asymptomatic hypoglycemia, if the neonate develops symptoms, then you will have to shift to the symptomatic hypoglycemia protocol. Now, what is this symptomatic hypoglycemia protocol? So this symptomatic hypoglycemia protocol starts with giving IV dextrose in the form of bolus at the dose of 2 ml per kg. For example, if you have a 3 kilogram baby or 3.8 kilogram baby, as in our case, so you need to use 2 into 4, that is 8 ml of 10% dextrose that should be given at this bolus, and this should be followed by an infusion which is given at the dose of 6 to 8 milligram per kg per minute. Again, repeat the blood glucose after 60 minutes. Now here, the next step will be dependent on whether the blood glucose level is less than 50 or more than 50. If the blood glucose level is more than 50, then for 2 consecutive hours, then at this point of time, you can just monitor sugars every 6 hourly and start feeds once 2 sugar values are above the 50 milligram per deciliter. Now, when you do that, you start tapering the glucose infusion rate to 4 milligram per kg per minute, and then gradually switch over to oral feeds. If the blood glucose level is less than 50 milligrams, now keep on increasing the glucose infusion rate at the increments of 2 milligram per kg per minute to a maximum value of 12 milligram per kg per minute. And after that, you can monitor the sugars every 30 minutes and see whether the sugar is more than 50 or less than 50, and accordingly titrate it. Now, one more important thing we should remember is a peripheral cannula can get blocked if you use 12.5% dextrose or more. So that's the reason why whenever you are giving IV dextrose, it has to be 10%. And if at all you are using 12.5 or 25% dextrose, then it's preferable that you give it through a central vein. And everybody knows placement of a central IV cannula is going to be very difficult, especially in neonates. So you should be equipped with that. Now, what exactly is happening in a diabetic mother? Why is this infant having so many problems? So this flow chart can summarize everything for you. So whenever there is a maternal diabetes, because of the hyperglycemia which is there in the maternal blood, there will be a compensatory hyperinsulinemic state in the fetus. So because of the response, because to the response of the maternal increase in blood glucose level, there will be fetal hyperinsulinemia. And everybody knows insulin is an anabolic organ, anabolic hormone. So it results in anabolism. So there will be basal cell hyperplasia because of the insulin, which is anabolic effect, which results in large for gestational age. Almost all parts of the body, all organs of the body enlarges, except few, which we'll be discussing as an MCQ in the subsequent class. And then you will have macrosomia. Whenever there is a macrosomia, there will be difficult labor because of the shoulder dystocia. And the child may have birth trauma, asphyxia, brachial plexus injury, and a fractured clavicle also. At the same time, in response to the insulin itself, there may be cardiac hypertrophy, which can manifest as asymmetrical septal hypertrophy of the interventricular septum, which is again one of the most common congenital, which is one of the most common congenital anomalies in infant of diabetic mother. Now, fetal hyperinsulinism is also going to impact the baby, not when the baby is in utero, but when the baby is delivered. So in response to the maternal hyperglycemia, the fetal hyperinsulinemia was seen. But this hyperinsulinemia soon after the birth acts on the blood glucose level in the neonate and starts reducing it drastically. Now this will result in jitteriness when there is severe reduction in the blood glucose level that can also cause seizures. Now remember, fetal hyperinsulinemia is also going to affect the fetal metabolism. It reduces the lung maturation rate, decreases the parathormone secretion, and it also will cause relative hypoxemic state, thereby resulting in polycythemia, increased red blood cell turnover resulting in hyperbilirubinemia, decreased lung maturation resulting in respiratory distress syndrome, and decreased parathormone maturation resulting in hypocalcemia and hypomagnesemia. And of course, at any point of time, if the maternal diabetes is associated with renovascular disease, or if there is a uteroplacental insufficiency, about 25% of the fetus may actually be small for gestational age as well. So in general, it means that the infant of diabetic mother is not always large for gestational age. About 25% of the cases will have small for gestational age because of the uteroplacental insufficiency because of maternal diabetes. So this is in brief regarding the pathophysiology. Now briefly to look at the spectrum of diabetic infant of a diabetic mother, the one of the thing, if we start from the chronology, you can see that most of the stillbirths or deaths in the fetal life occur in the third trimester in patients in infants with diabetic mother. There will be macrosomia, which is defined as a birth weight of more than 4,000 grams. Neonatal respiratory distress in the form of respiratory distress syndrome is also a well-known entity. Metabolic disorders or discrepancies in the form of hypoglycemia can be seen in 25 to 50% of the patient. Insulin is in excess in infants. So because insulin is in excess, ketogenesis is not going to be a problem in neonates with infant of diabetic mother. So there will be hypoglycemia, which is non-ketotic. There will be hypocalcemia and hypomagnesemia because of the decreased parathyroid maturation, and you can have coexisting polycythemia, hyperbilirubinemia, cardiomegaly in up to 30% of cases, and heart failure in up to 5 to 10% of the cases. Now, if you look into the infant of diabetic mother, this is how an infant of diabetic mother typically looks like: large for gestational age, chubby face, hairy pinna, small head circumference, and the lower half of the body, especially in the region of the sacrum, will be less well developed, resulting from caudal regression syndrome. So these are in brief regarding the spectrum of infant of a diabetic mother. Now, the LS ratio is a very important ratio which tells us about the lung maturity. And now it has been assumed that when LS ratio, that is lecithin sphingomyelin ratio, is assessed, and if the ratio is more than 2, the risk of respiratory distress is very low in general population. But there is an exception to this rule. So infants of diabetic mother, infants with erythroblastosis fetalis, and infants who have suffered intrapartum asphyxia, these are the three situations where their baby can still have a LS ratio of more than 2, but still they may be predisposed to respiratory distress syndrome. That means the general statement that low LS ratio is associated with very high risk of RDS is applicable for all, but the exceptions are these three: infants of diabetic mother, infants with erythroblastosis fetalis, and infants who have intrapartum asphyxia. Here, these patients have a very high LS ratio, that is LS ratio of more than 2, and hence LS ratio in these three subsets cannot be used as a surrogate for prediction of pulmonary maturity. So this is one thing you have to remember. Now next is an MCQ which is based on the organs which are going to have enlargement as an effect of anabolic action of insulin. So infant of diabetes is associated with enlargement of all organs except, the options are liver, kidney, adrenals, and heart. So what do you think the answer is? So here the answer seems to be kidneys. The answer seems to be kidneys. Just the answer seems to be kidneys. So almost all organs in an infant of diabetic mother can undergo hypertrophy and they appear enlarged. Exception for this general statement is the kidneys and brain. Kidneys and brain do not enlarge. Now, if you have to look at the infant of diabetic mother from anomaly point of view, the infant of diabetic mother is associated with a threefold increase in congenital anomalies, right from cardiac malformations, neural malformations, renal malformations, and GI malformations. All of them can appear. The most common cardiac manifestations would be asymmetrical septal hypertrophy of interventricular septum. If that is not given in the option, then you will have to look for ventricular septal defect. Now in neural abnormalities, all sorts of neural tube defects and holoprosencephaly and other neural migration defects can also be seen. But the key feature of neural abnormality in an infant of diabetic mother is caudal regression syndrome. The lower half is underdeveloped. Lower half of the body is underdeveloped. And in fact, this caudal regression syndrome is unique to infants of diabetic mother, and hence this caudal regression syndrome is found to be a specific marker of infant of diabetic mother. Renal abnormalities can be in the form of hydronephrosis, renal agenesis, and dysplasia, as well as double ureter. GI malformations in the form of duodenal as well as anorectal atresia, as well as situs abnormalities can be seen. There's also one more peculiar syndrome which is attached to infant of diabetic mother, that is lazy left colon syndrome or small left colon syndrome. So this is in brief regarding the spectrum of infant of diabetic mothers with respect to congenital anomalies. Penultimate slide, asking about a question: which of the following malformation in a newborn is specific for maternal insulin dependent diabetes mother mellitus? So here the answer, as I have already discussed in the previous slide, is called as caudal regression syndrome. Now what is this caudal regression syndrome? Now caudal regression syndrome is a rare disorder which is highly specific for infant of diabetic mother. That so specific that 200 to 4 times higher prevalence of caudal regression syndrome is seen in infant of diabetic mother than compared to that of other situations. Sacral agenesis and hypoplastic pelvis are the key features of identification here. And usually when this occurs, there will be coexisting malformations involving the sacral and the perisacral area, that is femoral hypoplasia, extrophy of the bladder, and clubfoot as well. So I'll go with the last slide. I have a spotters of infant of diabetic mother. Now this is an infant of diabetic mother who is having macrosomia. You see the lower half. Of the body. The lower half of the body is barely developed because of the caudal regression syndrome. There is macrosomia. The baby appears to be large. There is hairy pinna, small ear cartilage, hairy pinna, chubby face, and if you see, there is some degree of microcephaly also. Now if you take the X-ray of the baby, you see that after this L2 vertebra, you are not able to see any spine. This indicates that there is some evidence of caudal regression syndrome. This is also called as sacral agenesis. Now this third image is best typifying the lower half of the torso, which is completely underdeveloped, thereby resulting in what is called as caudal regression syndrome. Now with this, we complete the topic of infant of diabetic mother. I hope we have covered almost all aspects of infant of diabetic mother. In addition to that, we have also touched upon briefly the management aspects of hypoglycemia, both symptomatic as well as asymptomatic. Thank you.
Hello, am I heard? Okay. So hi everyone. Today we'll be discussing a very image-based topic from obstetrics on obstetrics ultrasound. We'll be taking this in over the next 3 days. Today will be on first trimester, tomorrow second trimester, and Friday will be third trimester. Because this can come as an image-based question, the ultrasound, because fetal medicine has become a very important part of obstetrics. So briefly, just let's look at the types of probes, the ultrasound probes that we use in obstetrics. So there are two probes that we use here. One is the transabdominal probe, and the other is the transvaginal. And you should know for which scenario, which type of probe is used. So you should know the characteristics of both. So the transabdominal probe, the frequency is around 3 to 5 megahertz. Whereas transvaginal, the frequency is much higher, 5 to 10. So what this means is that as the frequency increases, the clarity of the image is better. But the depth at which you can see the organ decreases as the frequency of the probe increases. So the opposite will be for transabdominal. Hence the frequency, since the frequency is little less in this one, it means that the clarity will be less, but it can see organs in the deeper region. For example, with transabdominal, if you keep the probe on the patient's abdomen, you can visualize still the retroperitoneal organ. But with transvaginal, you can see only organs that are just few centimeters away from the probe. So the penetration is more, meaning the depth of organs will be seen more clearly with transabdominal. The clarity or the visualization will be more with transvaginal. Transabdominal can be used anytime during the patient is pregnant. Transvaginal is specifically used in these three conditions. First trimester scans, because the baby is very small at this stage, you want good clarity to see the fetal heart rate and measure the crown rump length. If you want to measure the cervical length, because this probe will be directly in contact with the cervix, this will be a better way to assess. And if you're suspecting placenta previa, if the patient comes with bleeding PV, again in placenta previa, the placenta is in direct contact with the cervix. Hence, the probe will be in much close proximity. So in these three conditions, transvaginal probe will be preferred. Now let's quickly look at the type of ultrasounds that we do in obstetrics in all three trimester. In first trimester, we have a dating scan to see how old the baby is. And this is usually done between 8 weeks to the end of first trimester, that is 13 weeks and 6 days. The next thing is called as the nuchal translucency scan. This is a type of scan used for screening of trisomies and aneuploidies. And this has to be specifically done between 11 weeks to 13 weeks and 6 days. In the second trimester, we do something called as the targeted anomaly scan. The baby has become slightly bigger at this stage. So it will be easy for us to assess if all the organs has been formed properly anatomically. And this is usually done between the 18th week to the 24th week. The third trimester, we do something called as the growth scan to see if the baby is growing well. And this is usually done between 28 weeks to 36 weeks. Today, we'll be concentrating on the dating scan and the NT scan. So first trimester scan is done to see patient comes pregnant in the first trimester and you're writing her an ultrasound investigation. You would want to know if the baby is alive or not. Are you able to see the cardiac activity? Because abortions and miscarriages are common in first trimester. Where is the pregnancy located? Is it inside the uterus or is it outside? Because ectopic is one of the differential diagnoses of a failing pregnancy with bleeding PV in first trimester. Also, some pregnancy can be multiple gestation twins. So this will be the ideal time to diagnose if it is a singleton or multiple. And the most important thing for first trimester, very specific to first trimester, is the dating, especially in patients with irregular cycles. Because dating, when baby is dated in the first trimester, by measuring the crown rump length, it is 99% very specific. It can tell you how many weeks the baby is old. It is more specific than calculating the baby's age by last menstrual period. All right. So next, let's look at an MCQ based on this. A 24-year-old primigravida, she's 6 weeks of gestational age, first antenatal checkup, and you have done an ultrasound, and it shows the following image. The crown rump length is 5 millimeter, and cardiac activity is not visualized properly. So what will be your management? Your options are: plan for termination of pregnancy, get a second opinion, repeat after 1 week, and give progesterone supplements. So let's get oriented to this picture first. So this black thing is the gestational sac. The whole thing is the gestational sac. And this round ring-like thing is the yolk sac. And this very small peanut-like white colored thing is the baby, the fetus. So now they have measured the crown rump length and they have given it as 5 millimeter. All right. So now you need, and first thing is you have a measurement of crown rump length, and the other thing is you're not able to see the cardiac activity. So now your job is to find out, is this a miscarriage, or is the baby too small that you're not able to see the baby's heart clearly at this stage? Too early, so that you want to repeat a scan to make sure that the baby is still growing. So these are the two options that you need to look out for. You can easily cross out progesterone supplement. The role of progesterone supplements is very, very few in obstetrics, and I'll be covering that in subsequent sessions, but it is not for a patient who is diagnosed or suspected to have miscarriage unless the patient comes with threatened abortion. That is, patient comes with a bleeding PV, and by scan you see a baby with cardiac activity present. So get a second opinion is only when you're doubtful of something. So this can also be crossed out. So your options are either termination of pregnancy, suspecting a miscarriage, or repeat after 1 week because you're not sure if the scan has been done too early before the baby's heartbeat can be seen by scan. So let's look at the characteristic structures that we can see in a first trimester obstetrical scan. The first structure that you need to look out for is the gestational sac. So now this is the transvaginal ultrasound, and this teardrop-like thing is the uterus. This whole thing is the uterus, in fact. Okay. And you can see a very nice black color bubble-like thing, that is the gestational sac. The characteristic of a viable pregnancy is that gestational sac will be eccentrically located in the uterus. What does that mean? So when you draw a line like this in the center of the uterus, dividing the uterus into two halves, you can see that the gestational sac, the upper half is bigger and the lower half is smaller. That is, the line dividing the gestational sac is such that it does not divide the gestational sac into two equal halves. It is not equal. So that is what you call as an eccentrically located gestational sac, and this is a good sign. It is a sign that the baby is getting implanted well. So the next point is you will be able to see something called as the double decidual sac sign. And the double decidual sac sign, if you can notice, there are two circles around this gestational sac. Let me delete this so that you will be able to see it better. So if you can see around the gestational sac, there is this white color ring-like structure around the gestational sac. So that is the first ring, which is anatomically because of decidua capsularis. And then you have this bigger ring around the first ring, and that is because of decidua parietalis. So this causes the double decidual sac sign in the ultrasound. Next will be to look for yolk sac in the scan. yolk sac is seen inside the gestational sac. So if this is a very magnified view, this is the gestational sac, the black structure. And inside that, there'll be a white ring-like structure. And that is called the yolk sac. It is indicative that the pregnancy is an intrauterine one. And the yolk sac initially provides nourishment to the baby in initial few weeks. And once the placenta starts getting implanted really well, the baby will start deriving its nutrition from the mother. So by 14 weeks, this yolk sac would have completed its duty and it will disappear. Okay. So next, the most important thing is to look at the fetal pole. Fetal pole means the baby as such. So now if you guys are following me, so this is the gestational sac and this white ring is the yolk sac, and you see something, a blob like structure here. So that's the baby. This is actually the head. This is the abdomen, and these small things are the fetal limbus. So that's the fetal pole. The important thing with fetal pole is once the fetal pole is visualized, the next thing is you have to make sure if the baby is alive or not. So check if the cardiac activity is present. So when you're doing the scan, it will be like a flicker of movement. And next important thing is to measure something called as the crown rump length, because only by measuring this, you can date the pregnancy. Okay. So crown rump length is measured by keeping the view in a sagittal plane. That is, you should be seeing the baby from its side. So just follow with me. This is the baby's head. This is the nose, the mouth, and this is the neck. Okay. This is the baby's spinal cord. This is the abdomen. This whole area is the abdomen, and you can see the cord here and the legs. I hope I'm helping you. This is the buttocks of the baby. All right. So the crown rump length is measured on the sagittal view. This is very important. Otherwise, your dating is not accurate. The crown means the top of the head, and the rump is another word for the baby's buttocks. So it's a straight line that you measure from the top of the head to the buttocks, and the computer will give a measurement, for example, 5 millimeter, 6 millimeter, and it will automatically convert it into how many weeks of gestation the baby is. The computer, the ultrasound machine itself will give it. You do not have to calculate. Okay. So now by these three structures, when do you expect them to see? Gestational sac, you will be able to see 4 weeks of gestational age. That is from around the time she misses a period. Yolk sac will be +1, 5 weeks, around 5 weeks, and you will be able to see the fetal pole only around 6 weeks of pregnancy by transvaginal ultrasound. Okay, so 1 + 1 + 1, starting from 4 weeks. If you're doing the same scan by transabdominal method, as I said, the clarity or the visualization will be less with transabdominal. So the same baby, the same gestational sac, yolk sac, and fetal pole, you might be able to see it only 1 or 2 weeks after these expected weeks. So for example, the gestational sac, you might be able to see only at 5 to 6 weeks, yolk sac at around 6 to 7 weeks, and the fetal pole at around 7 to 8 weeks. I hope I'm clear. Okay. So now let's see, now that we know what are the structures that are expected in first trimester, let's see by ultrasound how we can diagnose a missed miscarriage. Missed miscarriage is where the mother will not have any symptoms of miscarriage, and by scan you incidentally found out that the fetus has died inside. So she'll not have any bleeding or pain. She would have come just for a routine checkup, and by scan you find out that the baby is dead. So how do you diagnose this by ultrasound? The first criteria is the gestational sac has reached more than 25 millimeter, but in scan, you're not able to see any fetal pole. So in this condition, it will be just a big black bubble with nothing inside, just the gestational sac, nothing inside. So at this stage, you can diagnose that the patient is having a miscarriage. The second criteria is, or the second clinical scenario will be like, there will be a G-sac, there will be a fetal pole also, and you are measuring the crown rump length, and it is coming to 7 millimeter. But even at 7 millimeter, you're not able to see the cardiac activity. So once the baby reaches 7 millimeter, you are expected to see the cardiac activity. So if you're not able to see, it means that the baby has miscarried. So this is the second clinical scenario. Third will be you're able to see the gestational sac and yolk sac, but you're not able to see the fetal pole and cardiac activity yet. In which case, what you do is you wait for 11 more days and repeat the scan to see if fetal pole with cardiac activity is seen. So this will be the third clinical scenario. Okay. The fourth will be a gestational sac is seen, but there is no yolk sac. You can wait for 14 more days to see if fetal pole and cardiac activity is visualized. So these four are very important criteria. This is how you diagnose missed miscarriage by ultrasound. First is by gestation size of the gestational sac, no fetus seen. Second will be fetus is seen and the crown rump length is 7 millimeter, but there is no cardiac activity. Third point will be gestational sac and yolk sac is seen, but nothing else is seen. You wait for 11 more days. And again, if at that time also, if you're not able to see a fetal pole with cardiac activity, you diagnose miscarriage. The fourth clinical scenario will be like there is a gestational sac, but there is no yolk sac. So then you give a little more time than the previous scenario, up to 2 weeks, 14 days, and then you see if the fetal pole and cardiac activity is seen. Okay. So let's go to the MCQ again. So here the important information, she's 6 weeks, crown rump length is 5 millimeter. So there's gestational sac, yes, there is fetal pole, there is yolk sac, all three are seen. Gestational sac, yolk sac, and the fetal pole and the crown rump length is 5 millimeter, but cardiac activity is not seen. But from our previous criteria, we know that you can wait up to the baby grows to 7 millimeter to see if the cardiac activity is seen or not. So let's give the baby some more time to grow and let's repeat the scan after 1 week to see if the baby has reached 7 millimeter. And at that time, you should definitely be able to see cardiac activity. At this point, you can still wait for the baby to become a little bigger. Okay, so the answer will be repeat the scan after 1 week. I hope I'm clear. All right. So the next question, as I said, the use will be to see if it is intrauterine or ectopic. This I will be dealing separately when I'm taking ectopic pregnancy. The number, again, if you can see here, the whole thing is gestational sac, the black thing, but if you can see there is a white septum like thing that is separating and you can see 2 heads here. So this is twin gestation. And again, here it is divided into 3 sacs. So this is triplet. Again, how to determine chorionicity and amnionicity by scan, I'll be dealing when I'm taking multiple pregnancy. All right. So let's go to the next question. A 28-year-old primigravida who is, who is 7 weeks by her LMP, and by that the estimated date of delivery is 11th of April. This we calculate by Negley's rule, right? 9 months plus 7 days to the LMP. But she has history of irregular cycles. Now, Negley's rule is only for somebody who has regular cycles. But on ultrasound, you find that the crown rump length corresponds to 6 weeks. By scan, it says that the baby's growth is only corresponding to 6 weeks. And by scan, you have calculated the estimated date of delivery as 20th of April. So there's a big difference, right? Almost 9 days of difference. So which EDD will be the correct EDD in this case? Is it the one that is calculated by LMP or by ultrasound by CRL? Or will you take another CRL and take an average, or do a second trimester scan and then decide which is the EDD? Let's look at this. Dating again, same picture. This is a crown rump length measurement. So how to go about this question is, when something like this comes, first you calculate the EDD by Negley's rule from the LMP. So you'll get a date 1. Second, by doing a ultrasound crown rump length, the machine will give you an expected date of delivery according to the crown rump length. That will be date 2. And see if the difference between these two dates is this much. If you're doing the scan at less than 8 weeks and 6 days, if the difference between date 1 and date 2 is more than 5 days, you take the ultrasound EDD. Again, if you're doing the scan between 9 weeks to 15 plus 6 days, and if the difference between the two dates is more than 7 days, you take the ultrasound EDD. If it is less than these two values, or if it is less than 5 days in case of 8 weeks or 7 days in case of this gestational age, you can still go ahead with the Niggles rule calculated EDD. I hope that's clear. Okay. So if the difference is more than 5 days, when the baby is less than 8 weeks and 6 days, or if it is more than 7 days in 9 weeks to 15 plus 6, you always take the CRL, because CRL is the most accurate way of dating the pregnancy. So now coming back to this question, by LMP, her EDD is 11th of April, and by CRL, her EDD is 20th of April. So the difference is 9 days. And this scan is done at 7 weeks, which is less than 8 plus 6 weeks. So we know that if the difference is more than 5 days, you need to take the ultrasound calculated date, that is the CRL based EDD. And yes, 9 days is more than 5 days. So the patient's EDD will be, I'm sorry, this is 20. Patient's EDD will be 20th of April. That is the one that is calculated based on crown rump length. All right. Okay. So the next important thing is the nuchal translucency scan. Again, for measuring this, the baby should be in mid-sagittal plane. You should be seeing the baby from the side like this. So this will be the head, and this will be the thorax. These tract-like structure will be the spine. This is the neck. And do you see a black clear space behind the baby's neck? This is the nuchal translucency, and this is seen in every baby. But when this crosses a particular measurement, it should alert you that the baby has a high chance of developing aneuploidies, especially trisomies. So very specific, nuchal translucency is done between 11 weeks to 13 weeks and 6 days, only during this period, when the crown rump length measures 45 millimeter to 84 millimeter. Okay. It is a marker for aneuploidy, especially for trisomies 21, 18, and 13. What is the abnormal value? When it is more than 3.5 millimeter, it is said to be abnormal and she'll require higher investigations. This is only a screening test, and it does not mean that the baby has Down syndrome or other trisomies. You'll have to offer her diagnostic tests after this. We'll be dealing this in fetal medicine. And if NT scan is done along with the mother's blood test, like measurement of beta HCG and PAP-A, it is called as the combined first trimester screening test. All right. The other things that you can see in first trimester are the ductus, baby's ductus venosus. You can see the waveform. Baby's heart, you need to see if there is tricuspid regurgitation, and if you're able to see the nasal bone. These three are soft markers, again markers, not diagnostic, markers that they will have, the baby might have trisomies. And again, another very important thing is to measure the uterine artery Doppler, because if the uterine artery Doppler is raised high level in first trimester, it is an indication that the patient might develop an early onset preeclampsia, that is preeclampsia at less than 34 weeks. It is a prediction that the patient might develop early onset preeclampsia. All right, so this is about the first trimester ultrasound in obstetrics. Tomorrow we'll be dealing with the second trimester. I hope that was useful. Thank you so much.
Good evening, everyone. Good evening, everyone. Today we are going to see INICET revision class 3. So today we are going to discuss some of the MCQs again in the same immunobullous disorder only. Same topic. First question: what is the percentage of oral involvement in pemphigus vulgaris? The answer is 50 to 70%. You should know the lesions of pemphigus vulgaris, as I told earlier in the earlier classes. Pemphigus vulgaris has bullae, flaccid bullae, which occurs in the body, mainly trunk and the extremities will be involved. In addition to the bullae, hello. Okay. If you can see the lesions which occur in pemphigus vulgaris, the body lesions has flaccid bullae which occurs in trunk and extremities, and the patient will also have oral ulcers as the oral involvement lesion. Hello. Okay. Oral ulcers and the oral lesions. So this oral ulcer sometimes can be the earliest lesion to occur in case of pemphigus vulgaris at the disease onset. So you should know the percentage of oral involvement in case of all the bullous disorders. So mucosal involvement. So if we see in pemphigus vulgaris, 50 to 70% of patients will have oral mucosal or any other mucosal involvement. And in case of bullous pemphigoid, 10 to 30% will have. Usually, the oral involvement in bullous pemphigoid is rare compared to the pemphigus vulgaris patients. So the percentage is very less, 10 to 30%. In linear IgA disease, the oral involvement is higher. 70 to 90% of patients will have oral involvement. And in mucous membrane pemphigoid, as the name indicates, the mucous membrane involvement is the primary lesion here. So 90 to 100%, almost all the patients will have mucosal involvement in this category. And in dermatitis herpetiformis, usually the patient will have vesicles and bullae in the extremities. So extremities and extensor surface. So here also the mucosal involvement will be rare. Next question: what is the earliest pathological change seen in the histopathology of pemphigus vulgaris? So the answer here is usually, as we all know, pemphigus vulgaris will have some split, intraepidermal split, but the earliest is to occur is spongiosis. Spongiosis is nothing but intracellular edema. This is the earliest finding, and intracellular edema with some inflammatory infiltrates will also be there. The type of inflammatory infiltrate which is occurring in this spongiosis is eosinophilic spongiosis. Before the bullae formation, this is the finding which will occur. So if we see the biopsy findings of pemphigus vulgaris, the earliest finding, as we discussed in the MCQ, it is eosinophilic spongiosis, which occurs before, well before the bulla formation, and the split, the level of split, as you might be knowing already, it is suprabasal split, as you can see here, suprabasal split. And the classical appearance, what you see in case of biopsy, is row of tombstone appearance. So here what you can see here is row of tombstone appearance. So this is called as row of tombstone. So the basal keratinocytes are arranged like this in a similar fashion. So this is called as row of tombstone. And in direct immunofluorescence, the classical appearance we discussed yesterday, it is chicken wire pattern. And next question is, what is the substrate used in IAF? IAF is nothing but indirect immunofluorescence to diagnose pemphigus vulgaris. So here, this is a very high difficult question, because you should know what are the diagnostic modalities to which are used in the common clinical scenario to diagnose this pemphigus vulgaris. Then only you can you will be knowing this about this indirect immunofluorescence, and you should know the procedure, how it is being done. Then only you know the substrate for this IAF. So if we see the answer for this is monkey esophagus. I'll explain you this in what all the investigations we are doing in case of pemphigus vulgaris in this question. The investigation, commonly what you can do to diagnose pemphigus or any bullous disorders, bedside test you will do Zang smear, as we discussed yesterday clearly about the Zang smear, what to be done and what not to be done. If a patient of pemphigus vulgaris is presenting with such a lesion, and if you take a Zang smear and if you see the acantholytic cell, it is more or less confirmatory that the patient is having pemphigus vulgaris. But you have to do further investigation for further confirmation and to diagnose it specifically. So what we are doing is, we can do biopsy of the bullae. We can do a biopsy. Either we can do a punch biopsy or shape biopsy we can do, and we can process it and see it under the microscope. And we discussed all the findings of biopsy also. Apart from this, DIF can be done. So this DIF, IAF are immunofluorescence studies. So this is more sensitive and specific compared to this biopsy. So this DIF immunofluorescence can be divided into two types: direct immunofluorescence and indirect immunofluorescence. Direct immunofluorescence, what you will do in this investigation is, you take a patient's skin sample, usually from the perilesional area, and you keep it in saline, not in usually in biopsy. You keep the biopsy sample in formalin for processing. Here in direct immunofluorescence, we keep it in saline and process it immediately. Or if you want to process it later, you have to keep it in a special medium for this, called as Michel's medium. So you have to take a biopsy sample of the patient, usually from the perilesional area, area, usually within around 2 centimeters from the lesion you have to take, and you have to send it for processing. And if you process it, and the patient will be having antibodies in the skin sample. So in the skin sample you have taken, and you are adding some fluorescent labeled antigens in this DIF. So fluorescent labeled antigens and antibody, they just react together to give this fluorescence. That is what we are seeing in the picture as a green colored fluorescent labeled fluorescence, which will be seen in case of DIF. So in DIF, we saw all the findings, what we see in case of pemphigus vulgaris and bullous pemphigoid. And apart from this, other type of immunofluorescence here we are doing. What we are doing is, we are taking the patient's blood sample and processing it. We are adding antigen to this blood sample, and we are adding an anti-IgG antibody to this antigen antibody complex. So what we are doing is, here we are using some substrate. This we are taking patient blood sample and adding it to a substrate which has normal skin antigen. So the substrate used to diagnose different type of pemphigus is different and will be varying. So what we use to diagnose pemphigus foliaceus is guinea pig esophagus is a substrate used, and For diagnosing pemphigus vulgaris, we use monkey esophagus as a substrate. And for diagnosing paraneoplastic pemphigus, we use rat bladder epithelium. So this is all the substrate which is used in case of immunofluorescence, the indirect immunofluorescence to diagnose pemphigus variants. So this you should remember by heart it and remember it. And the sensitivity of this immunofluorescence is around, sensitivity and specificity is always around 80 to 90%. Apart from this, ELISA is a test which is used to diagnose antibodies. So this also we can use to diagnose antibodies against the antigens, desmogleins. So this is the main investigation to diagnose. Apart from this, before starting treatment, usually for pemphigus, we give steroids and other immunosuppressants. So apart from this investigation, other supportive investigations such as complete blood count, liver function test, kidney function test, and test to rule out tuberculosis, and test to rule out any other immunosuppressive condition should all be done and ruled out before starting the patient on any treatment. So this is all about investigation you have to do for pemphigus. Next question is, what is phagocelbagam? Phagocelbagam, this is just a plain direct MCQ question. If you have read it, you can answer. Otherwise, it's very difficult. Phagocelbagam is nothing but endemic pemphigus. So endemic pemphigus is phagocelbagam that everyone might be knowing. What is the variant of endemic pemphigus which commonly occurs? Which is nothing but endemic pemphigus foliaceus. So phagocelbagam is endemic pemphigus foliaceus. So we'll see a few points about endemic pemphigus. It is seen in Brazil and South American countries, and it occurs due to some fly spread and fly bite. So the fly which causes this endemic pemphigus is black fly or simulium fly, and it usually occurs in the pemphigus foliaceus pattern, as I discussed earlier. Pemphigus foliaceus pattern. Pemphigus foliaceus pattern, the clinical presentation, you should be remembering it now. Usually the patient will not have bullae or any other intact vesicle, because the split at the level of split in case of pemphigus foliaceus is subcorneal level, which is more superficial and very superficial. So patient will be having crust like lesion. So the crust which is seen in case of pemphigus foliaceus is called as cornflake like crest. And so the patient will have the typical pemphigus foliaceus pattern, and in addition to that, the lesions will be getting restricted to the sun exposed areas. So this will give rise to a burnt appearance of skin lesions. So this is the clinical presentation of endemic pemphigus, and you should know the meaning of word phagocelbagam, which is nothing but wildfire. So this is all about endemic pemphigus. Next question, what is the most common malignancy which is associated with paraneoplastic pemphigus? So the name indicates the paraneoplastic pemphigus will be associated with some or other malignancy. So solely we are giving this name paraneoplastic. This also you should read to remember the answer. It is most commonly associated with non-Hodgkin's lymphoma. We'll see a few points about this. This is most commonly associated with non-Hodgkin's lymphoma, and apart from that non-Hodgkin's lymphoma, other malignancies which are associated with this condition is lymphoma, lymphoid malignancy, and Castleman's disease. And the prognosis of this condition depends upon the associated malignancy. If the associated malignancy has poor prognosis, then the prognosis is obviously going to be poor. Then the first symptom for this condition is recalcitrant severe painful oral ulcers will be, patient will be having this. This I had told you yesterday also. And in skin, what you can see in case of paraneoplastic pemphigus, polymorphous skin lesion. Polymorphous skin lesions are nothing but lesions of various morphologies, such as vesicles, bullae, pustules, plaques, erythema, non-specific erythema, everything all together will be there, and will give a very non-specific clinical picture. And the name of criteria which is used to diagnose paraneoplastic pemphigus is Anhart et al. Criteria. This you should be knowing the name. And extensive malignancy, in such cases, if you are suspecting paraneoplastic pemphigus, extensive malignancy workup such as complete blood count, peripheral blood smear, and bone marrow biopsy, CT scan, MRI, and PET scan, all malignancy workup should be done to rule out any kind of malignancy in such patients. Next question is, what is the antigen involved in case of IgA pemphigus? The antigen involved in case of IgA pemphigus is both desmoglein 1 and desmocolin and desmoglein 1. So we'll see about IgA pemphigus. IgA pemphigus, as I told in the previous classes, it is a variant of pemphigus vulgaris. So what is the difference between IgA pemphigus and pemphigus vulgaris is that the nature of immunoglobulin deposit. So it is IgA deposit in case of this, and it is IgG deposit in case of pemphigus vulgaris. So what you can see here is IgA deposit in the intraepidermal spread, and it has two variants, subcorneal variant and intraepidermal variant. These variants are named according to the site of split. What do they make in the biopsy or in the clinical level? So the subcorneal variant will have split at the subcorneal level, and the antibodies are formed against this antigen desmocolin. So in intraepidermal variant, the split where you can see is at the suprabasal level. This is just similar to pemphigus vulgaris, except that the antibodies deposited here are IgA antibodies, and in pemphigus vulgaris, the antibody deposited are IgG antibodies. So the antibodies are also again deposited against desmoglein 1 and 3 only, similar to pemphigus vulgaris. The most common site, it has some site predilection to occur in certain sites. This is axilla, flexures, and intertriginous areas. Unlike pemphigus vulgaris, which occurs mainly in extremities and trunk, this occurs in axilla, flexures, and intertriginous areas. With this clinical picture, you should be able to diagnose IgA pemphigus. And if you do and see in the direct immunofluorescence, you will see IgA deposits compared to IgG deposits in other variants. Next question is, which among the following is not a predisposing factor for bullous pemphigoid? So you should know about a predisposing factor for bullous pemphigoid to answer this question. So gluten sensitivity. Gluten sensitivity is a predisposing factor for dermatitis herpetiformis, not for bullous pemphigoid. This you should be knowing. And dermatitis herpetiformis is actually a different kind of pathomechanism it follows. There occurs gluten sensitivity, and antibodies are formed against epidermal tissue transglutaminase. So this is totally different from bullous pemphigoid. The predisposing factors for bullous pemphigoid includes these are all the predisposing factors: trauma, mainly UV radiation, burns, skin grafting, influenza vaccination. These are all the non-specific predisposing factors. Apart from this, as I told in the earlier SAS class, certain drugs and systemic diseases are also associated with this causation of bullous pemphigoid. So what are the drugs association with bullous pemphigoid is furosemide and other loop diuretics, spironolactone and other potassium sparing diuretics, ampicillin and other antibiotics also. Other antibiotic groups, cephalosporin, penicillin, are also associated with causation of bullous pemphigoid, and gliptin group of anti-diabetic agents, and certain neurological diseases and neuropsychiatric diseases such as Parkinsonism and stroke, epilepsy are all associated with causation of bullous pemphigoid. So this is all for today's class. We have discussed some of the important MCQs which they might ask from this topic. I hope this session is useful. Thank you.
So, good evening to all of you. And today, expected question in surgery, and we'll be discussing this question. A male presented with a below image, which of the following is true? Option A, orchidectomy done. Option B, urinary diversion done. Option C, mixed aerobic and anaerobic infection is seen. Option D, anti-gas gangrene serum given. What will be the appropriate answer here? The correct answer is, for this question, is option C. What is that we are seeing in this image? All that we are seeing in this image is a kind of a funous gangrene. And you will be able to see that this also is associated with necrotizing fasciitis. Because if you look into this image, it goes even to the anterior abdominal wall. Usually, funous gangrene you would have seen restricted to the scrotum. But if an image given like this, the funous gangrene associated with necrotizing fasciitis involving the skin and the fascia of the upper aspect of the thigh and the lower abdomen, according to this picture. Now, what is funous gangrene? Funous gangrene is a type of necrotizing fasciitis involving the scrotal skin. And the most important aspect of this funous gangrene is it will involve all the structures that surrounds the testis, except the testis will be spared. So the testis will be spared, the tunica albuginea will be spared, and it will be intact. So most of the time, whatever the gangrenous tissue, the necrotic tissue, the debris, that can be completely removed. So total debridement can be done, and you can allow a fresh granulation tissue to happen. So this is all about a funous gangrene. It's about a necrotizing fasciitis of male genitalia or the perineum, and involving the entire skin, dartos, the external spermatic fascia, internal spermatic fascia, and tunica vaginalis, cremasteric fascia, all the fascias, including the dartos and the fat, everything will be involved, and except the testis will be intact. And testis with tunica albuginea. Whenever you see the testis, along with this an epididymis. So epididymis major, epididymis minor, and it continues as vas deferens. Now, testicular protein, you should understand that testicular protein is also called self protein. Testicular protein is called self protein. They can ask you this question. In the body, what do you mean by self protein? Self protein, classical example for self protein, number 1, testis. Number 2, the lens protein. Okay, the protein which is there within the lens is the self protein. Now you should understand this self protein will not be recognized by body's immune system. Will not be recognized by body's immune system. So that means this protein is a hidden protein and a self protein and concealed protein, and this is not recognized by immune system. Means what? The entire body is exposed to the immune system, so that our immune system will not affect our body tissues, organ, or any aspect of the body, and is being concealed. Yes, and not exposed to the immune system, should never be exposed to the immune system, even later part of the life in any given situation. There's the reason why there will be an important question asked in your exam. What is the question that will be asked in your exam? Is suspected, understand this, suspected testicular cancer. They can ask you, what is the most common testicular cancer in adults? The most common testicular cancer in adults is seminoma. Suppose you suspect a seminomatous tumor. A patient comes to you with a heaviness in the testis, sudden increase in size of one of the testes, and with a short history. On examination, there is a hard palpable nodule in the testis, and when you do an ultrasound, there is a solid tumor which is seen in the testis. So you have a suspicion because of this is most commonly seen in elderly age group. Suppose the given patient here is more than 60 years and you have a high suspicion of a testicular cancer. The question here is, what will be the next step? What will be the next step in the suspected testicular cancer? The next step in the suspected testicular cancer is what? Can you do a FNAC? Can you do a fine needle aspiration cytology to look into whether this testis has a cancerous or malignant cells or not? Now try to understand, in a suspected testicular cancer, you will never understand, you will never do a transneedle scrotal biopsy. You will never do a transneedle scrotal biopsy because you will breach the testicular barrier. The testicular barrier is tunica albuginea. So tunica albuginea can be breached and the self protein can get exposed. There are two things which can happen here. What two things can happen? If it is going to be malignancy, doing a transneedle scrotal biopsy can cause spillage of malignant cells. Spillage of malignant cells that can come out of the testis, out of tunica albuginea, tunica vaginalis, internal spermatic fascia, cremasteric fascia, and external spermatic fascia, dartos, and skin. So it can come onto the layers of the covering of the testis. So it can deviate from the oncological principles of surgery. So that is one aspect. If suppose the given suspected nodule or a tumor in the testis turned to be benign, what can happen? You can expose this testicular protein, yes, by breaching the layers of the testis, especially tunica albuginea, and you can expose that into the immune system. So once you expose the immune system, the immune antibody itself will destroy the testis. So there could be an auto destruction of the testis that can happen if it is going to be benign. So either ways, okay? So auto destruction by the immune system of the body to destroy the testis because it is being exposed now. Understood? So things are very clear. In a suspected testicular cancer, you will never ever do a transneedle scrotal biopsy. Doing a transneedle scrotal biopsy, number one, if it is going to be malignancy, it can deviate the oncological principle of surgery. It can cause spillage of cells from the testis into the layers of the scrotum. Because the regional lymph node for testis is para-aortic lymph nodes. So the next step of spread for a testicular cancer is going to be para-aortic. In case you're going to do a transneedle scrotal biopsy, it can come into the layers of the testis. Suppose it's going to breach the tunica vaginalis, it can go to iliac group of lymph nodes. In case if it is going to the skin, dartos, skin and external spermatic fascia and all those layers, it can go to the inguinal lymph nodes. So what could be an early stage of a cancer? You can, by doing this biopsy technique of transneedle scrotal biopsy, you can make them to move on to second and third stage of the cancer. So it should be avoided. And next, if it's going to be benign, there will be self-exposure of self-protein. Will expose the self-protein of testicular protein to the immune system and can cause auto-destruction. 2 points over. Now they can ask you, similar appearing exam, similar appearing question elsewhere. Where else you will not do a needle biopsy in the body? Very important question. One, I said testis. Number two, I will say pheochromocytoma. Pheochromocytoma. See, in pheochromocytoma, you will not do a needle biopsy because of the risk of bleeding, number one. Number two, because of the risk of hypertensive crisis. It can lead to hypertensive crisis. One, it can cause bleeding and it can cause hypertensive crisis. And next will be any vascular tumor in the body. Any vascular tumor in the body, you will avoid hemangioma, angiosarcomas, any of those vascular tumor in the body, you will definitely avoid doing a needle biopsy. So this all you need to definitely know. And also at another tumor, that you should avoid needle biopsy is hepatic adenoma. Because it is also a vascular tumor. It can also cause bleeding. So 4 things that you will remember for needle biopsy should be avoided. 1 is the suspected testicular cancer. Number 2 is pheochromocytoma. Number 3 is any vascular tumor of hemangioma or AV malformation or any of those vascular related tumors. You should not, and hepatic adenoma you should avoid. So these are the 4 things that you avoid needle biopsy. Very clear. And similarly for lens. That's the reason why any trauma to the lens, generally lens does not rupture. Suppose lens ruptures and testicular proteins are exposed, then it can cause destruction of the testicular protein and it can lead to blindness. Okay, and of course this will be temporary and you can replace the lens in case it is not proceeding to endophthalmitis. Is it clear for all of you? Yes, great. So we have seen very important point that one reason that we started discussing is because tunica albuginea is so resistant to necrotizing fasciitis. Yes, and the testis is well preserved. It is well preserved. Understood? Great. Now, another important aspect that you will always understand, the dihydrotestosterone which is produced from the testis is one of the most important growth factor for the prostate. Very, very, very important. Dihydrotestosterone which is produced by the testis. Yes, it's a very important factor for prostate growth. And this is one of the important aspect of why do we do a orchidectomy in patients with advanced prostatic cancer, because the growth, the progression of growth can be stopped by doing an orchidectomy. Understood? And this is one of the type of hormone manipulation. And not only that, dihydrotestosterone, yes, dihydrotestosterone, 5-alpha reductase inhibitor. Yes, 5-alpha reductase inhibitor and finasteride. Finasteride is an important drug that is given in BPH, benign prostatic hypertrophy, that will act on 5-alpha reductase inhibitor. Yes, where the level of dihydrotestosterone level will be drastically reduced. Understood? Yeah. Now let us just finish this question and we call it a day. Yes, Funes gangrene is a necrotizing fasciitis of male genitalia and the perineum that can be rapidly progressive and fatal, not treated promptly. The mortality rate has been reported as high as 67%, and risk factors of Funes gangrene include perirectal abscess, diabetes, obesity, chronic alcoholism. Diabetes, very, very important factor. The often polymicrobial, and it is said Peptostreptococcus, aerobic and anaerobic organisms, Peptostreptococcus, very, very important. And this causes inflammation of vasa vasorum. What do you mean by vasa vasorum? You know what do you mean by vasa vasorum? Vasa vasorum means the blood vessel supplying blood vessel. So inflammation of that is one of the important risk factor in Funes gangrene, necrotizing fasciitis. So the clinical signs include perineal and scrotal pain, inflammation and necrosis, crepitus. The diagnosis is largely made by a clinical suspicion. Correct? However, a radiological finding on a CT imaging can assist with the diagnosis, including soft tissue, air associated with fluid collection within the deep fascia, prompt and aggressive surgical debridement of a non-viable tissue and broad spectrum antibiotic are necessary to further prevent further spread of this infection, and a spread of fecal diversion with the endorectal tube serves as an option for a conservative fecal diversion in case it is going to go beyond the skin and the muscle and the fascia. If there is a damage to the external anal sphincter, patient may require a colostomy. Patient frequently require return trips to operating room for further debridement. Okay. Negative pressure wound therapy. This is also very, very important. Yes, this is WAC therapy. Negative pressure wound therapy system have been shown to reduce hospitalization time and also by aiding. Okay. By aiding in wound healing, correct? By aiding in wound healing, and the reconstructive strategies involving skin grafting are needed when large tissue defects results in extensive tissue damage. Okay, so things are very, very, very clear that as long as it is going to be very, very superficial and this is a superficial infection, it's going to be treated with adequate antibiotic and debridement, and things should suffice. But in case it's going to involve the sphincter or deeper into that, and probably a colostomy might be required. And you also should know if there is a loss of tissue is more, than the skin grafting and reconstruction might also be required. And there's another phenomenon, there's a negative pressure wound dressing, where the entire area is sealed with like an offside, like a sheet, with it is like airtight and watertight. And then you put in a suction tube into a suction apparatus with an appropriate pressure, and then you will see that it is getting all the debris are getting sucked, and it cleared, and the fresh granulation tissue builds up, and then it involves in the kind of regeneration and wound healing. So it's very, very clear that this is all about necrotizing fasciitis, Fuenius gangrene we have been discussing today. And thank you very much. And I'll see you tomorrow with next expected question for INICET November 2021. Thank you very much.
So good evening, everyone. Welcome to the discussion of anesthesia, most important questions for INICET today's session. So in today's session, I'm going to discuss a very, very hot, important topic in anesthesia, which is called as mechanical ventilation. So before discussing the question per se, I'll just discuss the topic of mechanical ventilation in short, and then finally I'll show you the question. Okay, so this is what we are going to do today, right? So So I'm going to discuss a topic which is called as physiological consequences of mechanical ventilation. Okay, so what am I going to discuss? I'm going to discuss physiological consequences of mechanical ventilation. Okay, physiological consequences of mechanical ventilation. All right. So to understand the physiological consequences of mechanical ventilation, you should understand the difference between normal breathing and mechanical ventilation. Okay, so you should understand that mechanical ventilation is nothing but giving a mechanical breath to the patient. It is just giving a mechanical breath to the patient. So you should understand the difference between a normal breath and a mechanical breath, right? So please do remember that I'm talking about the physics of breathing, right? So you should understand that breathing is nothing but movement of air. Breathing is nothing but movement of air. Air is traveling from the atmosphere all the way down via your airways and into your alveoli. So this is your atmosphere here, and this is your alveoli here, right? So air is going to move from the atmosphere via the airways, and finally it is going to reach your alveoli. So if there has to be movement of air, one thing that is mandatory is pressure gradient. So there should be adequate pressure gradient if you want air to flow. Now imagine you are not breathing. Imagine you are not breathing. You are not inspiring or you are not expiring. If you are not breathing, which is basically you are not inspiring, not expiring, there is no net movement of air. If there is no net movement of air, there is no pressure gradient. Means your atmospheric pressure as well as your alveolar pressure is going to be the same. The atmospheric pressure and alveolar pressure is going to be the same, right? So imagine, just take, for reference purposes, let's consider atmospheric pressure to be 0. So if you are not inspiring and not expiring, at that particular point of time, your alveolar pressure is also going to be 0. Right. Now imagine you are going to take an inspiration, or you are going to undergo the process of inspiration. So when you undergo the process of inspiration, what is happening? Your diaphragm is going to contract.
Your diaphragm is going to contract downwards. So this contraction of diaphragm, what does it lead to? It leads to the expansion of your intrathoracic cavity. It leads to the expansion of your intrathoracic cavity, right? Now, the expansion of intrathoracic cavity results in one peculiar thing, right? Your thoracic pressure or your alveolar pressure was previously 0. Now, because of the contraction of your diaphragm, your thorax is expanding, and as a result of that, your alveoli is also going to expand. The previously alveolar pressure was 0. From that 0 alveolar pressure, now that 0 pressured cavity is again expanding. This 0 pressured cavity is expanding means your alveolar pressure becomes negative. From 0, it is going to become negative, right? So now you are going to have a pressure gradient. Your atmospheric pressure is 0. Your alveolar pressure is negative. This leads to the inflow of air into the lung. So inspiration normally happens as a result of a negative intrathoracic pressure as a result of diaphragm contraction. That is why normal breathing or spontaneous breathing is otherwise called as negative pressure ventilation. That is why it is called as negative pressure ventilation. It is called as negative pressure ventilation because inspiration happens as a result of negative intrathoracic pressure. Now imagine you are going to initiate mechanical ventilation in one patient. When you are going to initiate mechanical ventilation, you would obviously have some indication, like say the patient is having respiratory failure or the patient is in some sort of shock. The patient might be not really able to take care of the patient's own hemodynamics. So in that scenario, when you are initiating mechanical ventilation, what happens? When you are initiating mechanical ventilation, there is a slight difference in respiratory mechanics, right? So your diaphragm is somehow not contracting and the diaphragm is not really able to generate an adequate negative pressure for ventilation to happen, right? So what actually happens here is, now in this particular mechanical ventilation, in order to generate that pressure gradient, you give a positive pressure at the level of atmosphere. Now you attach the patient to a ventilator and that ventilator will give a positive pressure at the level of atmosphere at the starting point of your airways so that it can drive air into the alveoli, right? So here, as a result of inspiration, your intrathoracic pressure becomes positive. That is why modern ventilators are supposed to give something which is called as positive pressure ventilation, right? So I'll just tell that again. What happens in your mechanical ventilation is that, you attach a patient to a ventilator. That is going to deliver a breath to the patient. It is going to cause movement of air from the ventilator to the patient using a positive pressure that is given at the starting point of airways. So as a result of this, your intrathoracic pressure becomes positive during inspiration. Whereas in normal ventilation, your intrathoracic pressure is actually negative. That is why it is called as negative pressure ventilation, whereas what we call here, it is called as positive pressure ventilation. Okay. So what do you want to understand is your positive pressure ventilation is absolute reversal of respiratory physiology or absolute reversal of respiratory mechanics. It is absolute reversal of respiratory mechanics. So because this is a 15-minute discussion, I'm only going to focus on one very, very important change which happens in your respiratory system as a result of this absolute reversal of mechanics. Okay, so I want to light a shadow on what really happens in your respiratory system while you are trying to, or while the patient is initiated on mechanical ventilation. Okay, now again, so I'm going to talk about one respiratory consequence. Okay. Now, I want to take you back to normal ventilation once again. See, this is your normal lung here. Okay, this is your normal lung here, and you know that you are going to have a lot of alveoli here in your normal lung. Okay, so these are the alveoli which are present in your normal lung, and you are normally breathing. In between these alveoli, what do you have? You have something which is called as pulmonary vessels. You have something which is called as pulmonary vessels. Yes or no? Now, when the patient is undergoing the process of inspiration in normal scenario, when the patient is breathing on its own, it causes a negative intrathoracic pressure. Inspiration results in negative intrathoracic pressure. Yes or no? So your lung expands. Yes or no? your lung expands, and as a result of lung expansion, what happens is your alveoli are going to be here, and they are also going to expand with air. And the pulmonary vessels which were present, or pulmonary vasculature which was present in between these alveoli, they also start to expand. So during inspiration, what generally happens inside your lung is there is going to be pulmonary vasodilatation. Now, you know what really happens when there is systemic vasodilatation. Imagine you are having a condition where there is systemic vasodilatation, say sepsis. In systemic vasodilatation, what happens? There is going to be vasodilatation, which leads to peripheral pooling of blood. And as a result of peripheral pooling of blood, the venous return towards the heart is reduced. And as a result of that, blood pressure is reduced. Similarly, whenever there is pulmonary vasodilatation, what happens? You know that the pulmonary vessels finally end up in your left atrium. Yes, pulmonary vessels finally end up in the left atrium. Your pulmonary vein finally drains into your left atrium, right? Because of pulmonary vasodilatation, during inspiration, your left atrial preload is decreased. During inspiration, your left atrial preload is decreased. And as a result of decrease in left atrial preload, there is going to be decrease in left ventricular preload. And because there is a decrease in left ventricular preload, the overall cardiac output is going to be reduced. The blood pressure is going to be reduced. So my whole summary point is, when you are breathing normally, during inspiration, there is a small fall in blood pressure. Why does it happen? Because during inspiration, there is a negative intrathoracic pressure. Because of a negative intrathoracic pressure, there is pulmonary vasodilatation. Because of pulmonary vasodilatation, there is a reduction of left atrial preload. Because of reduction of left atrial preload, your left ventricular preload is also going to come down, which results in a decrease in blood pressure. So this is a normal physiological phenomenon, reduction of blood pressure during inspiration. In certain conditions, in certain pathological conditions, like say severe bronchial asthma, and in conditions like cardiac tamponade, what can happen is there might be an exaggeration of this physiological phenomenon. There might be an exaggeration of this physiological phenomenon. And that is what is called as pulsus paradoxus. Your medicine teacher or faculty would have already discussed that. So pulsus paradoxus is no paradoxus. Instead, it's just the exaggeration of a physiological consequences. So what I've told you is, normally there is going to be a small fall in blood pressure, but that fall in blood pressure is going to be less than 10 millimeters of mercury. That is going to be less than 10 millimeters of mercury. If the fall in blood pressure during inspiration is more than 10 millimeters of mercury, it is called as pulsus paradoxus. Now, this is a question. Second question here is, pulsus paradoxus is normally seen in conditions like severe bronchial asthma and cardiac tamponade. These are all questions which have been asked so many times in your exam. Now, this is a medicine question. I'm not really going into the depth of the medicine question, but what I want to highlight is what actually happens in mechanical ventilation. So in mechanical ventilation, as I've already told you, there is reversal of respiratory mechanics. So what happens here is, again, this is your lung here, and in your lung, you do have alveoli, right? So in positive pressure ventilation, what happens is you are giving a positive pressure at the level of atmosphere so that air is being driven into your lung, right? So as a result of this, as a consequence of this, during inspiration, your pressure inside the lung is more. There is positive pressure in the thoracic area. There is positive pressure inside the lung. Right. So as a result of this, during inspiration, your pulmonary vessels, which would have been like this previously, now gets contracted, or there is pulmonary vasoconstriction. So during inspiration, suddenly because of the intrathoracic pressure, there is going to be pulmonary vasoconstriction. Now this acts as a pump. Which drives blood from the pulmonary vasculature into the left atrium. So in your positive pressure ventilation or in your mechanical ventilation, during inspiration, the left atrial preload is going to be more. There is going to be an increase in left atrial preload. So as a result of increase in left atrial preload, obviously your left ventricular preload is going to increase. And as a result of increase in left ventricular preload, your blood pressure is going to increase during inspiration. So will your cardiac output. I'm not talking about the general blood pressure or general cardiac output. I'm just talking about the phasic variation of blood pressure and cardiac output in your mechanical ventilation. During inspiration, the blood pressure rises. Now, you know that during normal inspiration, when the patient is in spontaneous ventilation, there is a small dip in blood pressure. Exaggeration of that phenomenon is what is called as pulsus paradoxus. But in mechanical ventilation, during inspiration, there is going to be an increase in blood pressure. Again, this is the reverse of what you see in normal breathing. So this phenomenon is what is called as reverse pulsus paradoxus. This phenomenon is what is called as reverse pulsus paradoxus. Okay, so reverse pulsus paradoxus. Pulsus paradoxus is seen in conditions like bronchial asthma, cardiac tamponade, etc., etc. The normal phenomenon is seen in normal ventilation itself or negative pressure ventilation, but reverse pulsus paradoxus is a phenomenon which is exclusively seen in positive pressure ventilation. And what do you mean by reverse pulsus paradoxus? Increase in blood pressure or phasic change of blood pressure, which is increase in blood pressure during inspiration in a patient who has been initiated on positive pressure ventilation. Okay, this question has not been asked, but you should know that because of the COVID pandemic situation, mechanical ventilation has become a hot topic in both your NEET exam as well as your INICET exam. So they are consistently asking questions from the physiological consequences of positive pressure ventilation. And one such physiological consequence which they have not been discussed yet is reverse pulsus paradoxus. And that is why I wanted to throw light on this particular point. Okay, so based on this discussion, let's discuss the question which I formulated for you, right? So this is the question: reverse pulsus paradoxus is seen in. Your options are cardiac tamponade, bronchial asthma, positive pressure ventilation, and negative pressure ventilation. You know that in cardiac tamponade and in bronchial asthma, you see something which is called as pulsus paradoxus. Positive pressure ventilation is associated with an increase in blood pressure during inspiration, which is called as reverse pulsus paradoxus. And finally, negative pressure ventilation is usually associated with decrease in blood pressure during inspiration, which is less than 10 millimeters of mercury. So your answer to this question would be positive pressure ventilation. There are so many high-yield MCQs from the topic of mechanical ventilation. This is the start of such a series where I'll be discussing more and more questions from positive pressure ventilation and mechanical ventilation for you. Okay, I hope you enjoyed the question. I hope you understood the concept of positive pressure ventilation and reverse pulsus paradoxus. Thank you. Have a good night.